el Congreso, el primer Congreso Colombiano de Neurociencias y muy contentos de poder tener esta sesión que lideraremos en esta mañana conjuntamente con los profesores invitados, expertos en estas interacciones entre salud mental, neurociencias, filosofía de la mente. Tenemos un bloque muy centrado en estos diálogos entre psiquiatría, neurociencias, neuropsiquiatría. Entonces, espero que puedan disfrutar de esta parte. Welcome, everyone. We are so happy that you have here with us in the first Colombian Brain Health Congress. Today, we will have a group of speakers. They are so experts in trying to elucidate the potential links between neuroscience, psychiatry, and neuropsychiatry. So we hope you have able to join and to engage in the vibrant discussions with our speakers. So welcome, everyone. Juan.
Hi everyone, welcome. Good morning and welcome to the third and final day of the first Colombian Brain Health Congress. We have another exciting lineup of speakers and activities for you today. First, we begin with Dr. Jesus Ramirez Bermudez, who will present narratives in neuropsychiatry and health. A staff neuropsychiatrist at Mexico's National Institute of Neurology and Neurosurgery, Dr. Ramirez Bermudez bridges clinical services, research, and the humanities. Clinically, he managed complex presentations such as delirium, catatonia, and rare misidentification syndromes, while his research explores autoimmune encephalitis, mood disorder, neuroimaging, and typical belief of information. He is a leader in Latin America in the bridge between neuroscience and philosophy. Please welcome Dr. Ramirez Bermudez.
Thank you very much for that presentation. And I am really pleased to be here in this brain health wonderful meeting. It has been truly inspiring to hear all the presentations in the previous days. So today I am going to talk to you about brain science, but I will make a conceptual transition from brain science to clinical narratives, as I think this is a way forward into what I have called here an ecological neuropsychiatry framework. I think I will also switch between English and Espanol. I will do perhaps both, as I see that here in the public we have English-speaking people, but also Spanish-speaking English. So the standpoint of this presentation will be the clinical care of persons who suffer from states of psychosis. It's not my only interest, but I will use this as sort of an axis for analysis of the neuropsychiatric problems. And I will present the clinical epidemiology research program on psychosis due to structural brain lesions. And I will focus on the specific problem of autoimmune psychosis. Now, as we will see, the data analysis reveals a significant heterogeneity in terms of psychopathology and pathobiology. So this leads us towards a case formulation that will rely on this that I have called an ecological neuropsychiatry framework. So consider this case. This is a case that was published by my colleague, Yvonne Flores Medina from the Institute of Neuropsychiatry in Mexico. She's a clinical neuropsychologist, and she studied this case of Mrs. G, who reported that her children had been kidnapped and that the persons living with her are in fact their doubles. The imposters are also kidnapped victims who have their memories erased and an electronic device implanted, which is why she tries to get along with them. Now, the kidnappers also implanted a chip in her through which they can alter her perception of reality and in turn make her real children present themselves looking like strangers. She claims that several customers at her shop are in fact her children, who ask a series of questions disguised with other words as a way of testing her. Mrs. G must answer in a specific order to these questions to recover her family. Due to the undercover nature of the questions, she never manages to answer them correctly. So, as you can see, the case has a complex delusion, a systematized delusion, with features of both Capgras syndrome and Fregoli, the Fregoli delusion. Now, this is a case of schizophrenia. It's not a neurological case, so to speak. But as we know, some clinical phenotypes like the Capgras delusion can serve as a bridge, a psychopathological bridge between the realms of psychiatry and neurology. So it is an interesting case study to try to formulate a cognitive neuropsychiatry framework that aims to explain delusions through the resources of cognitive science. So my colleague, besides the medical approach, including molecular imaging, that revealed some interesting patterns of this hypoperfusion in the cingulate cortex and the retrosplenial cortex. Perhaps the most interesting part was that she found that this patient had a specific abnormality in self-directed signaling, which is a neuropsychological feature that relates to the sense of familiarity, as if the patient had a loss of familiarity, which could be accounted as the first factor in a two-factor explanation of delusions. Now, I want to use this case to present this framework, the cognitive neuropsychiatry framework, developed by Peter Halligan and Anthony David in the UK. And this cognitive neuropsychiatry framework relies on descriptive psychopathology through narrative accounts, phenomenological interviews, and clinimetrics. Also in neuropsychology through hypothesis-driven cognitive assessments, bedside examinations, and psychophysiology. And of course, neurological studies, including laboratory tests, physical and neurological examination, brain imaging, and electrophysiology. So we think that these three pillars, so to speak, of the study of psychosis in neuropsychiatric patients increase the explanatory power of the approach in the case of something as striking as a delusion. Now, personally, I found that this approach by Dr. Uta Frith and Chris Frith from the UK also, which I call the dual process approach to psychosis, is a resource to understand the functional role of explicit and implicit metacognition. So I should explain a little. So in the lower part of the slide, you can see a model of implicit metacognition. This means that even before the patient has any conscious awareness of any particular mental representation in her conscious experience, she already has a number of processes, neurocognitive processes, which are below the level of awareness. And this can be regarded as processes of monitoring and control. Monitoring and control of the transmission of neural signals along several brain networks. And this process leads to the formation of mental representations. But once that these mental representations, which are already in the conscious space of the patient, in her awareness, so to speak, these images or representations appear in the phenomenological space of the patient, in her own awareness. And from there, these images can undergo a process of explicit metacognition. So this is why this is a dual process approach, because we can have disturbances in signaling and in the cognitive process at both levels. We can use this framework to explain, for instance, hallucination. Once the patient sees the hallucination, the implicit metacognition has already gone wrong. But once the hallucination is in the conscious space of the patient, she can still make explicit metacognition process on it. So she can formulate that the hallucination is not real, or she can believe it is real. So, for instance, a cognitive therapy approach to delusions or hallucinations would work on the level of the explicit metacognition. Whereas to work in the implicit metacognition aspect, we would need perhaps other resources, perhaps pharmacological resources or neuromodulatory resources. Now, to explain the first and this second levels of explanation, we need some resources from molecular neuroscience. For instance, here we see a meta-analysis of the presynaptic dopaminergic function in the striatum, which is perhaps the strongest theory and resource we have to explain psychosis. So this is just the meta-analysis by McCutcheon, which shows us that this hypothesis actually has a strong empirical support with Hedges G, which is to say an effect size of 0.68, which is from medium to large. But we also need resources to test the metacognition part of the framework. So with Yvonne Flores Medina, we use several resources, but specifically we use the resource of measuring meta-memory. So we use a test of memory, and then we test the meta-memory, which is the awareness of the patient of her own disturbances in memory or her performance. So these patients, our patients with psychosis, have overconfidence errors. And these overconfidence errors have a strong correlation with the psychotic symptoms of the patient. Now, the problem leads us to neuropsychiatry because we also use this clinical phenotype, the Capgras delusion, to approach patients with, for instance, autoimmune psychosis. This is a case of anti-NMDA receptor encephalitis, also with the Capgras delusion. The patient believes that their relatives are imposters and who intend to kidnap him. And in this case, the patient has delusions, hallucinations. He transitions into a catatonic state with severe cognitive disturbances. And the molecular imaging shows us, in this case, a strong asymmetry in the metabolism. So the right hemisphere is, in fact, in this case, hypermetabolic, and the left hemisphere is hypometabolic. So this is a piece, an interesting piece towards an explanation. But here we have another case of Capgras delusion. So I'm presenting three cases. In this, the third case, we have a patient with a Capgras delusion, but this is related to a brain tumor. As you see, the patient has this this tumor, which is located in the medial aspect of the frontal lobe, in the prefrontal cortex, and it's affecting mostly the right hemisphere. As you can see, she has important edema in the right frontal cortex, and the lesion is going from the dorsal aspect all the way into the corpus callosum, affecting mainly the dorsomedial aspect of the frontal cortex, as well as the cingulate cortex, the anterior cingulate cortex. Now, this patient also has a Capgras syndrome. She has catatonic symptoms. She has severe dysfunction in cognitive processing, but also a problem, a motor problem, affecting mainly her capacity to walk. So the question is, after the surgery, will we see actually a remission of the delusion? Because in the case of the patient with schizophrenia, she has been refractory to all treatments. In the case of the patient with autoimmune psychosis, he had a complete remission after immunotherapy. Now, what will happen in this case in which we have a structural brain lesion? So after the surgery, you can see there the MRI after the surgery. We can see that the surgeon did a great job, right? He extracted completely the brain tumor. There is still some a small lesion in the dorsomedial aspect of the cortex, but the tumor is completely gone. Now, the patient recovers cognitively, not completely, but mostly, and she recovers also in terms of the motor problems she had. Now she can walk perfectly. She has no longer catatonic symptoms, but she still persists with a Capgras delusion. Now, by doing the clinical history, we found out that she had been under forced isolation in her house because her mother probably had some degree of psychopathology. So she had been isolated for 7 years. So she has two risk factors or two etiological factors. One is this mistreatment of the patient, this conduct of being isolated for 7 years. And on the other hand, we have the brain tumor. So we have two potential explanations for the case. Now, this doesn't help us to make any kind of reductive explanation, like the kind of explanation that perhaps a neurosurgeon or a neurologist would like. Because in clinical neurology, we like to have like this kind of one-to-one correlations between brain locations and clinical signs or symptoms, right? So the motor cortex explains any disturbance in motor functioning. But in psychiatry, we can see this kind of problem that is illustrated here by Germán Berrios, the famous Peruvian psychiatrist that is professor in Cambridge. So he shows us that the same symptom can be produced by two different lesions in different regions of the brain, or that one single location can lead to two different symptoms. So we need to consider the construction of the symptom. And the construction of the symptom is influenced, of course, by neurocognitive processes that can be approached through a computational framework. But also we need to consider the psychosocial configurators of the symptom, which are important from a ideographic perspective, which is to say a longitudinal study of the case. Like in the case of this woman with a brain tumor, a Capgras delusion, but also a history of 7 years of being isolated. So of course, to approach this complexity in the formation of symptoms related to brain lesions, we need to account for structural and functional connectivity, right? For instance, in my own institution, we do structural connectivity through diffusion tensor imaging. And we think that also functional connectivity can be very, very helpful. This is recent work that I saw published a couple of months ago by Pines and colleagues, mapping lesions that cause psychosis to a human brain circuit and propose stimulation. So they through the functional connectivity analysis, they show that the subiculum would be the most specific and sensitive part of the brain leading to psychosis in patients with neurological disease. So now I would like to present you a bigger picture of the kind of patients that we see in the Institute of Neurology. Some of my colleagues here, like Dr. Juan Orjuela, have been there, and they cannot let me present this wrongly, because they know that there are a large proportion of patients with neurological disease who actually go into psychopathological patterns of many different kinds. So this is the psychosis program. We have more than 2,000 patients treated for psychosis. In the hospitalization neuropsychiatry ward, coming from the fields of general psychiatry or the field of neurology and neurosurgery. And more than 700 of these patients have psychosis in the context of neurological disease. The main causes are, of course, epilepsy, autoimmune disease, major neurocognitive disorders, cerebrovascular disease, Parkinson, Huntington's, and so on. Now, for us, after making a statistical analysis of these cases, we came to two conclusions that we think that are interesting conclusions. The first one is that cognition is definitively an indicator of a possible neurological disease. Now, of course, primary psychosis like schizophrenia is also related to cognitive disturbances. But if you make a MoCA test, which is probably a good tool to use in these cases, patients with schizophrenia will typically have between 18 points and 25 points. So they will have a disturbance, but not a severe disturbance. Now, in case of patients with psychosis due to brain disease, they typically have 10 points in the MoCA test. So this is a large difference between both groups. And we don't agree with many clinicians, psychiatrists, or neurologists that think that making cognitive tests in the context of acute psychosis is unhelpful. In fact, we say the opposite. It is helpful. And we don't like that kind of explanations in which clinicians say, of course the patient will have a cognitive problem because he is psychotic or she is psychotic. That is not a real explanation. That is a pseudo explanation, because what we need to account for is, why is there a cognitive disturbance in the first place? What is the cause and what is the consequence? Psychosis is the cause of the cognitive disturbance, or is it the other way around? And the severity of the cognitive disturbance is very important. The second problem is catatonic symptoms. Now, these are not so frequent, but for instance, 3% of our cases of primary psychosis had catatonic symptoms, whereas 19% of our neurological psychosis, so to speak, or psychosis due to brain disease group had catatonic symptoms. This is partially biased by the fact that our population has a lot of cases of autoimmune pathology. So I don't think this would be the same in other scenarios, but nonetheless, I think that the presence of catatonic signs is a red flag, so to speak, to suspect a neurological disease. Now, I will show you a couple of videos, so I hope that this is interesting for those of you who are clinicians. Okay, so this is the kind of problems that we see in the field of autoimmune psychosis. This is autoimmune catatonia. The first case, the one above. The second one is a problem of opsoclonus, which is a different kind of problem. But well, this is the kind of behavior that we will see in these patients. These are many signs, like the patient has grimacing, she has mutism, she has sometimes these verbigerations, which are all catatonic signs. So we made a study of patients with anti-NMDA receptor encephalitis, and we found that they have many catatonic signs. In fact, most of them are catatonic. In our own sample, 60 or 70% of the patients have catatonia. Now, if we find catatonic signs in the context not only of psychosis but also delirium, this increases significantly the risk of finding an autoimmune pathology. And this has two potential consequences. The first one is that by using antipsychotics without using immunotherapy, we can sometimes see a clinical worsening of the patient, sometimes even with signs of neuroleptic malignant syndrome. We're not sure that these signs are actually caused by the antipsychotics, because we compared patients with and without antipsychotics, and both developed this kind of signs. But nonetheless, if we only treat these patients with antipsychotics, we don't see a significant improvement. Whereas immunotherapy is very, very helpful in these cases. So this was a sample of more than 200 patients with delirium. And when we found catatonic signs, there was an increased risk of having anti-NMDA receptor encephalitis. In fact, the odds ratio was of 10. And we did another study. This is a prospective study of patients with neuropsychiatry with anti-NMDA receptor encephalitis. So it's a sample of 100 patients compared to 60 patients who had a negative determination of for NMDA receptor encephalitis in the cerebrospinal fluid. And we found that these patients had really many signs and symptoms. We have a list of more than 100 signs and symptoms, all sorts, catatonic signs, psychotic signs, all sorts of cognitive dysfunction, from any neglect to memory disturbances, all sorts. And psychotic symptoms are present in 81% of the cases. This is our current model. So we think that patients start with psychosis, some cases with mania, some cases with anxiety or depression, but then they go into one of the two following phenotypes: delirium or catatonia. And many patients will have catatonic delirium, which has been some interesting field of controversy in the last years. Some people, like Mark Oldham, believe that catatonic delirium is actually a thing, so to speak, whereas others, like Dr. Paula Trepax, thinks that there's not such a thing, no? Like delirium with catatonia. In fact, in the DSM-5, there is a criteria for exclusion of catatonia in the context of delirium. But we think that the DSM is wrong in that regards, and now the International Classification of Disease from the World Health Organization removed that criteria in their own criteria of catatonia. So we align with that new decision, because they also have a chapter of catatonia that is independent from the chapter of psychosis. In the DSM, catatonia is within the chapter of psychosis, which we think is an error, because not all patients with catatonia are psychotic, and we can also see catatonia in other contexts, mainly acute encephalopathy of autoimmune origin or other origin as well. Now the residents in my hospital are always one step ahead, so they speak of the catalirium, ¿no? El famoso catalirium, decían, es un paciente con catalirium. They already had a word for it. Okay, now, well, one other feature, no? 8% of the patients in this sample died, mostly of status epilepticus. And but this is a large improvement, because me and my colleagues did a work 25 years ago in encephalitis. We still thought it was viral encephalitis. This autoimmune encephalitis had not been discovered yet. So in fact, we thought that most cases were viral encephalitis, and the mortality rate was 20%. In fact, the group from Barcelona, Dalmau, Graus, Titular, which have led this research, have shown that also in their own sample, the mortality has gone from 25% to 10%. So it's largely in agreement with our own observations. So, as you know, the British group by Thomas Pollack and colleagues, Belinda Lennox and so on, they have built this yet controversial set of criteria for autoimmune psychosis. There has been controversies there between the Barcelona group and the UK group. But we think that the criteria for autoimmune psychosis are valid and reliable, and are a helpful tool for psychiatrists. Why so? Because the Graus criteria for autoimmune encephalitis start when you already did a lumbar puncture, an EEG, an MRI, and in psychiatry we don't always have those resources. So when you do a systematic search for antibodies in all psychotic patients, the actual rate is very low, 3%. Instead, when you use red flags, you can find an increased amount of cases. So we think that the red flags, these proposed criteria for possible autoimmune psychosis, are a helpful criteria for psychiatrists to select which patients should actually undergo through an immunological test. Now, this is another video that I want to show to you. This is also a case of autoimmune psychosis, but in this case, the patient went through this dangerous landscape, so to speak, of the Cotard syndrome. Now, these patients, of course, gave me informed consent for presenting this in an academic setting. Fortunately, they could recover and provide themselves. Now you can see the level of distress of the patient. She has a severe cognitive disturbance. We could not even make the MOCA test. And she has hallucinations, these nihilistic delusions. She thinks that her body is burning and the world is burning, and she's already dead. She has no eyes, and so on. Now, we did, in this case, immunotherapy, but it was not enough. She's a case of systemic lupus. This is the patient in the neuropsychiatry ward after she received immunotherapy. She's pointing at some part of the building in which there's a fire. Okay. She spent 4 months in the hospital. So we finally did ECT, and she went through a complete recovery, right? But after immunotherapy, I think we need both in some cases. Always immunotherapy first, and most of the times it's enough. But sometimes we still need to use psychopharmacology or, in some selected cases, ECT. Now, she recovered completely, fortunately. You can see the changes in her psychomotor behavior and so on. This is the molecular imaging of the case. In the second row, you can see the actual pattern in the patient, in which you can see there is a strong hypermetabolism in both frontal lobes and the hypometabolism in the occipital lobe, which is the pattern, an increase in the anterior parts and a decrease in the posterior parts. We put below a control, a normal control subject, because the reviewer was not familiarized with molecular imaging, so he thought that the actual FDG PET of the patient was unremarkable. But if you compare both, you can see that the increase in metabolism in the frontal lobes and the decrease in the occipital lobe is actually quite severe. Now, how can we explain the emergence of these mental symptoms? This is really, for us, an interesting question, right? So, in a paper with Dr. Mario Mendez from the University of California in Los Angeles, we published this paper in which we tried to provide an explanation regarding these abnormalities in molecular imaging. So, as you know, the preconneus, this part of the brain, is related to first-person perspective task, highest metabolic rates in the conscious resting state, and a dominance in the right hemisphere for self-processing. Some of our patients have some asymmetry in the metabolic patterns with a specific dysfunction or hypometabolism in the right hemisphere. And we did systematic research on many patients with anti-NMDA receptor encephalitis through molecular imaging, and we found that pattern, right? The hypometabolism in the occipital cortex. This has been replicated by other groups. It had seen previously by Dr. Provasco in the USA. And we don't have an explanation. We need two pieces of information to provide an explanation. First, why should patients with anti-NMDA receptor encephalitis, why should they have occipital hypometabolism? And the second question is, why should this hypometabolism lead to the specific psychopathological pattern in the patients? So we actually don't know, but we think that it is related to what you can see in the upper part of the slide. You can see that the highest concentration of NMDA receptor is actually in the medial aspect of the parieto-occipital cortex. And this part of the brain is, of course, related with the alpha rhythm, which is a marker of wakefulness and awareness. And that part of the brain is also related to the phenomenological experience in dreams. So some researchers think that this is highly related to a conscious state. In fact, we think that the contemporary theories of consciousness, like the higher order theories or the predictive processing theories or the global workspace theory and the integrated information theory, can provide at least part of an explanation. Because, for instance, the integrated information theory is consistent with our observations. So we think that anti-NMDA receptor encephalitis is, in fact, a model to study conscious awareness and disturbances. So finally, I would like to present you two more things. The first one is the results of a paper that was just accepted for publication these days, in which we make a test of immunotherapy for autoimmune psychosis. It was a sample of 164 patients. They received plasma exchange, immunoglobulin, and so on. And the recovery was really important for psychotic symptoms. Cognitive dysfunction also had an important response, but not remission in many cases. So that's still a challenge for us. Now, finally, I would like to present slight conceptual change into what I will call a narrative approach to these cases. Because initially I presented cases in which you have already a neurological explanation, but you also have a psychosocial explanation for the same case. So you need to integrate both in the same framework. So in the few minutes that I still have for this presentation, I would like to propose a conceptual framework for a neuropsychiatric formulation that integrates the nomothetic and the ideographic perspectives, aiming for an explicit recognition of neurobiologial and contextual factors and their integration into the analysis of the life trajectories of our patients. For instance, in the lower part of the slide, you can see there a case of a woman with anti-NMDA receptor encephalitis who had nonetheless a sustained suicidal behavior over the years. And we found out that patient had been subject of sexual abuse during her childhood and adolescence. Now, she didn't present a major psychopathology before the encephalitis, but after the encephalitis, she had like a pattern that resembles complex PTSD, right? So we have two factors once again, and we need to put them into the same perspective. So we use this dual formulation. The nomothetic approach is, of course, a statistical approach that relies on diagnosis, the general features of the case, but the ideographic approach aims for a case formulation in which you track the specific features of the case, because not all patients with psychosis are the same, right? They have different backgrounds, different contexts, different life histories, so we need to account for that. And that's what we do in this framework, the clinical narrative framework that we are using these days. So allow me to present a couple of experiences on that, and this will be the last slides in my presentation. This is part of the Oaxaca area in Mexico. So we have here the case of a patient who has psychotic symptoms in the context of encephalitis, herpetic encephalitis, but she was misdiagnosed, really. No, we didn't know she had encephalitis. We thought it was a case of schizophrenia. This is from many years ago, and we didn't approach systematically these psychotic patients with these tools. So the presentation was really a case of aphasia. And the relative, the mother, would tell us that the patient had forgotten Spanish. She would only speak in her mother tongue, which was Mije. Okay, so she would only speak in Mije, no longer in Spanish. So we thought it was a psychotic disorder, but truly it was a case of aphasia due to herpetic encephalitis. Now, this is a second case in which we will travel to the mountains of Monterrey, in the north of Mexico, and we have this case of a young woman who has also a case of aphasia, but in this case due to traumatic brain injury related to the criminal organizations in Mexico. So in this case, the sociological context leads to a traumatic brain injury in the patient, and she develops also a very severe case of aphasia. She had jargon aphasia. She would only speak like an invented language, something like me, and that was all of it, right? For several months. But the boyfriend, it was not it was not the clinicians, it was the boyfriend, discovered that she could sing perfectly only in English because she had lived a couple of years in London. So she could sing in English, not sing in Spanish, and she could not talk in English nor in Spanish. She could only sing in English. So that was our tool for rehabilitation, and she recovered completely. I couldn't believe the case because she had a complete recovery. Of course, it was a case of traumatic brain injury, and we know that they have a better prognosis. But I admit that for a few months, I thought that I had cured the patient, right? I had some kind of even delusions of grandeur myself, thinking that, wow, I saw a case of aphasia that actually was cured. But then we saw another case of aphasia that didn't have that impressive recovery. She comes from this part of Mexico, which is Valle de Chalco. This is one of the poorest parts of the city. So this patient has been victim of bullying, sexual abuse, poverty, mistreatment, all the sociological features. But she never has the attitude of a victim. She's a very strong woman that sells perfumes. And in that context, she had a traumatic brain injury leading also to a case of, in this case, aphasia. Jargon aphasia. She would only speak like an invented language. In this case, it resembled something like Greek. I don't know why, but we couldn't understand one word of the patient, and she couldn't understand one word from us. So it was a case of global aphasia. And she had aggressive behavior and suicidal attempts. So it was really chaotic, this case. But we discovered that the patient was able to make calculations. So she had completely preserved numerical cognition. It was very surprising for us because if we wrote words down, she could not understand it. But if we wrote down any mathematical calculation, she would solve it. So she became capable of selling candies in the street, competing with other forms of informal underemployment in my country, where in the streets she would start selling these candies, and she was able to earn enough money to sustain her family, but she could never recover any language. So my point here is that we need to account for the conscious experience of the patient, the behavioral interactions, the neuropsychological processes, and we need a model of functional neuroanatomy, but also we need to account for the level of the general physiology of the organism, and for sociocultural systems where we find risk factors like threat, deprivation, inequality, and so on. And I would like to frame all of this as an ecological system of relationships. I think that is the framework, and it needs to be a historical framework. First, we have a general history leading to large-scale social history, the family history, the community history. This is all setting a lot of risk factors or protective factors. And we also need to account for the ontogenetic and developmental processes and the interpersonal history of interactions. So, well, that was the presentation. Thank you very much. I am very grateful with Hernando Santamaria for putting together this wonderful meeting. Thanks a lot.
Thank you, Doctor, for the presentation. We have a couple minutes for questions. I would like to ask if anyone has questions.
Voy a hacerlo en español para
Claro.
que puedan y sea un poco más fluido. Bueno, primero, muchas gracias por la presentación. Eso es enriquecedor para mí particularmente. Ya hemos discutido, nos tenemos acá la oportunidad de hacer un registro de unos casos de encefalitis autoinmune y creo que en perspectiva me gustaría conocer mucho cómo hacen ustedes para hacerle el seguimiento a estas poblaciones en el sistema de salud mexicano y cuáles son los parámetros en los que se pudieran basar para evaluar de pronto recaídas de la actividad autoinmune, porque si no es con crisis, es muy difícil que podamos saber si hay una nueva actividad de la enfermedad. Entonces, a veces se nos complica un poco la forma en la que pudiéramos saber si hay una recaída y pues en las barreras que tenemos en el sistema donde muchos de nuestros pacientes no llegan a los centros donde hacemos el abordaje inicial, pues me gustaría conocer cómo han logrado.
Muchas gracias, doctor. Es una magnífica pregunta. Mire, los primeros casos que nosotros vimos fueron 2013 probablemente. Ya ve que los artículos de Dalmau salieron en 2009, 2007 los primeros trabajos, primero en lupus, luego en teratomas y finalmente en 2009 ya el paper más famoso, ¿no? del grupo de Dalmau. Tardamos un par de años en ponernos al corriente y los primeros casos que vimos eran justo casos donde había habido encefalitis herpética años antes. Recuerdo un caso de un neurólogo que me envió del Instituto de Nutrición de México a nuestro hospital y lo presentó como un caso de esquizofrenia catatónica, porque la paciente tenía todos los signos de esquizofrenia, lo que le llamamos los psiquiatras signos de primer rango, delirios de control, la paciente pensaba que sus pensamientos eran leídos por otras personas, etcétera, ¿no? Entonces, era un caso fenomenológicamente muy parecido a psicosis y había signos catatónicos que iban y venían y no la ayudábamos con nada. Es un caso donde también usamos terapia electroconvulsiva sin éxito. Y fueron mis colegas, la doctora Carmen Ojeda y la doctora Mariana Espínola, quienes decidieron hacer la prueba de anticuerpos y vimos que tenía anticuerpos positivos, dimos inmunoterapia y se recuperó por completo después de años en ese estado psicótico y de catatonia. Entonces eso nos hizo como believers, por así decirlo, ¿no? Y entramos también en una fase a veces como de exagerada entusiasmo, ¿no? De que ya queremos ver encefalitis autoinmune por todos lados y no siempre lo hay, ¿no? Pero con el tiempo hemos aprendido que el 10% de nuestros pacientes tienen recaídas y las recaídas efectivamente no son iguales a los primeros episodios. Primero, la mayoría de los pacientes no tienen recaídas. Con el tratamiento nosotros damos mucho rituximab o ciclofosfamida. Tenemos un seguimiento a 5 años. El doctor Enrique Mendoza de Panamá hizo una tesis con seguimiento a 5 años y solo el 10% tienen recaídas y las recaídas suelen ser más cognitivas y psiquiátricas que caracterizadas por crisis, pero sí son episodios claramente distinguibles donde las personas habían tenido buena funcionalidad social, económica, cognitiva y de pronto tienen un cuadro psicopatológico muy severo con signos cognitivos muy importantes. Por ejemplo, pueden cursar con afasia, con heminegligencia. Hemos tenido varios pacientes de encefalitis asimétricas muy interesantes o presentan en ese contexto nuevamente síntomas de psicosis. Ahí hay un riesgo de pensar que son secuelas. Ese es otro de los problemas que hemos enfrentado, ¿no? Algunos colegas piensan, pues son secuelas de la encefalitis. No, no son secuelas. Yo vi a los pacientes cuando salieron y se recuperaron y no tuvieron síntomas psicóticos en 1, 2 o 3 años. Entonces, claro, existe la posibilidad de que se induzca un proceso primario, como los que he mostrado, ¿no? En personas que tienen antecedentes de riesgo y demás. Pero si el caso presenta signos catatónicos, alteraciones cognitivas severas, y si claramente hay un episodio distinguible con respecto a la línea de base posterior a la inmunoterapia, yo creo que debe de hacerse nuevamente la prueba. Ahora, estos pacientes de recaída a veces tienen un electro normal, porque en el primer episodio el electro suele ser anormal, en la recaída no siempre. La resonancia puede ser muy inespecífica o tener pocos datos patológicos, o cuando los tienes son muy sutiles y dudosos. Y el PET es probablemente el elemento más sensible, pero también da muchos falsos positivos. Entonces, al final hay que hacer la prueba de anticuerpos, ¿no? Y aún con los anticuerpos, un porcentaje tiene anticuerpos negativos y puede no tener pleocitosis. Y algunas veces mis colegas prefieren hacer la inmunoterapia ya como un test diagnóstico, pero yo creo que casi siempre, por alguno de los métodos previos, capturamos el caso. Lo que pasa es que no hay que ser siempre tan escépticos, ¿no? Algunos colegas son muy escépticos y aunque el PET está normal y el paciente tiene bandas oligoclonales y tiene un MOCA de 5 puntos y hay una historia muy convincente, el paciente no lo compran, ¿no? Como decimos en México, no lo compran. Entonces, también hay clínicos que, por el contrario, ¿no? Sobrediagnostican. Yo creo que hay que tener esa precaución, pero si la persona ha tenido una buena remisión y de pronto tiene un nuevo episodio, hay que pensar que puede ser una recaída porque el 10% lo van a tener.
Muchas gracias de nuevo, doctor. Our next speaker is Dr. Joan Camprodon Jimenez, who is an associate professor of neurology and psychiatry at the Harvard Medical School and founding director of the Division of Neuropsychiatry and Neuromodulation at Massachusetts General Hospital. He earned his MD and PhD from the University of Barcelona, where he trained in psychiatry and neuroscience. His research focuses on the use of multimodal neuroimaging and brain stimulation to investigate and treat neurological and psychiatric disorders. Welcome.
Muchas gracias. Sí, se coge automáticamente. Igual. Bueno, buenos días. Muchas gracias de nuevo a los organizadores del curso por invitarme. Es un placer. Estoy aprendiendo mucho estos días sobre ciencia concretamente, pero también sobre el trabajo que hacéis aquí, este enfoque maravilloso sobre salud cerebral, que realmente creo que en muchos aspectos estáis liderando desde la Javeriana y en Colombia en general, y es un placer poder colaborar y ser parte de este proceso. La charla de hoy será sobre neuropsiquiatría y neuromodulación de precisión. Y creo que antes de hablar de estos conceptos, seguramente, o de la charla en sí, queremos definir neuropsiquiatría, neuromodulación y qué atrae la precisión a este espacio, ¿no? ¿Qué problemas podemos solucionar? ¿Y en qué se diferencian estos conceptos de conceptos clínicos y científicos más tradicionales? Aquí, estos son mis disclosures. Sorry, I think I'm meant to speak in English. So what do we want to solve with precision neuropsychiatry and precision neuromodulation? So the idea of precision generally, what brings to mind is the fact that we're not trying to solve population-based issues clinically, or come up with therapies or solutions that address. ¿Sí? ¿Se me oye bien? ¿Así mejor? Ok. Espera. ¿Mejor así? Okay. So the idea we're trying to solve patient-specific issues, right? So one of the problems we're trying to solve is the one of clinical heterogeneity. There's this apparent exceptionality of psychiatry if you compare with the rest of medicine. What kind of, how we formulate our cases, our level of access to biological pathophysiology. So that's one of the issues we can address. We'll discuss it. The second one is not just the clinical, but the biological heterogeneity. Right? If you analyze or observe 10, 100 different brains for even healthy people, they're not the same, right? And when we're trying to identify or develop treatment solutions for brain disorders, that heterogeneity, let alone that one driven by disease, but the one driven by just the biology of the brain, needs to be addressed, needs to be considered, and needs to be taken into account when we are actually designing treatments. And that leads us to treatments, right? Treatment development. How have we traditionally developed treatment in psychiatry primarily? To a certain extent in neurology. We just got very lucky, right? Serendipity has been our friend. And as a clinician, I'll take it because that gives me more treatment options that I can consider for my patients. But that's a problem if you're thinking about the pipeline for development, because we've been stuck for quite a while. And that's because serendipity is only as good as it gets if you get lucky. But I think changing the approach to a more bottom-up approach, where we are actually understanding pathophysiology, identifying biomarkers, and using that information to develop new therapies is critical. And it's something that in this precision framework we've been able to do. And I will discuss a few of these examples. And beyond some of these examples for specific therapies, I think it's important to know that we actually do have a fair amount of good therapies, safe and effective. The issue is oftentimes who should get what when, right? Among all the different options we have. And that also requires precision approaches that are not just trying to individualize the therapies themselves, but individualize the treatment selection process. Provide tools for clinicians that are evidence-based that allow them, of all the different options that I have, given the demographic, biological, clinical characteristics of this one patient who's sitting in front of me, what treatment should I select to minimize the time to finding a safe and effective therapy? So we'll try to go over these 4 problems and see how we can solve them in this framework. But first, let's try to define or identify some of these concepts. So what you see here is an inverted pyramid that goes from the more microscopic approaches in the bottom and the more macroscopic approaches at the top. And this tries to illustrate that approaching the brain, understanding the brain, health or disease, can be done through many different levels of analysis, which are often linked to different types of tools that allow you to analyze the brain at these levels of analysis. And it's important to understand that there isn't one level that is more important than others. And it's also important to understand that causality goes from the bottom up, but also from the top down. So we have genes that encode for molecules. We have molecules that make up cells. Cells are connected in synapses. These synapses define microcircuits that actually lead to the brain regions that we understand at the more microanatomical level. We have circuits or systems or networks that actually, these different brain regions connected to each other through white matter pathways that facilitate synchronous or asynchronous processing dynamics. So either structural or functional connectivity. Then we have the organ dynamics, right? We have blood flow, CSF flow, molecular or cellular immunological processes that leads to the brain functions: behavior, cognition, emotion, movement, perception. These are the brain functions that when they break down, when they become maladaptive, we call signs or symptoms, right? Signs, if we objectively observe them with our exam, symptoms, if this is part of the history of the patient. And for the clinicians in the room, if we put signs and symptoms together, that's the very definition of clinical syndromes, right? Clinical syndromes are the presentations that individual patients bring up, and our goal as clinicians is to define those clinical syndromes to be able to formulate the case and come up with a treatment approach. But again, beyond this clinical syndromes, this single patient level, there are also group level or population dynamics that are important. That's what epidemiologists will study. And as we've seen some of the presentations in earlier days, they're cultural, social, even religious dynamics that define some of these very complex exposomes that are also relevant to understand the brain in health and the brain in disease. So again, because of the complexity of the brain as a phenomenon of study, it's important to know that probably there isn't a single level that will give you the whole truth. But there's a trick here, is that if you are approaching the brain from a molecular perspective, you may only be able to come up with molecular definitions of brain function or brain disease. That doesn't mean that there aren't other levels, but you just have to be aware that you're approaching the brain at the molecular level, your tools are for molecular neuroscience, therefore your models will be molecular models. But there's more to the brain than your one level of approach. But you need to know what your level of approach is. What is your level of biological analysis? Because that will define how you formulate the questions, that will also define the models that you're able to generate. And for us in neuropsychiatry, I would argue that this systems or network or circuit neuroscience approach is particularly relevant and important. The one that anchors us, the one that defines our approach, biological approach to understanding brain function and brain disease. And that is because as clinicians in this complex brain health neuropsychiatry space, we're particularly interested in understanding disorders of behavior, cognition, and emotion. And brain functions, behavior, cognition, emotions, and others, are encoded at the circuit level. So that doesn't mean that there aren't other levels that are also relevant, but the molecular, the cellular levels are relevant to cognition, behavior, and emotion to the extent that they condition, biologically, they condition the circuit dynamics, these processes that happen at the circuit systems or network level. So we're going to be approaching the brain from this perspective. Again, that's not better than any other perspective. It's one that is particularly helpful to work in this clinical space of integrated clinical neurosciences or neuropsychiatry. But there's, beyond this more pathophysiological rationale, there are also some more pragmatic therapeutic approaches or rationales of why you would want to frame your work at the circuit level. We have three main types of treatments in the clinical neurosciences. We have pharmacology, and pharmacology, the entry point for pharmacology is the molecular point, right? So you modulate the brain at the molecular level. Then we have the non-somatic therapies, if you want. These are rehabilitation, whether it's physical therapy or cognitive therapy, gait, vestibular rehabilitation, the psychotherapies as well. So these are treatments that interact with the brain at the functional level, at the behavioral, cognitive, emotional, motor, sensory level. And last, we have devices, brain stimulation, neuromodulation therapies, which intervene precisely at the circuit level, right? We are able to use different forms of physical energy, not chemistry, most of the time electrical or electromagnetic energy, although there are tools that are using ultrasounds or near-infrared lights or microwaves. These are more novel experimental tools, but most of the tools that we have that we can use in clinical practice are using either electrical or electromagnetic energy. And we're basically talking to the brain in its own language, right? We're able to modulate these electrical dynamics that are computations that lead to these adaptive or maladaptive brain functions that particularly the maladaptive ones are the ones we want to address and modulate and change. So this is going to be our biological framework when we think about neuropsychiatry, neuromodulation, the circuit neuroscience approach. But it's not always obvious how we go from circuits to clinical practice to phenomenology, particularly in the more behavioral health aspects of brain health in neuropsychiatry. So here on the left side, you have how we traditionally define depression, right? Strictly phenomenologically, right? So it's these 9 different signs or symptoms in specific combinations for specific times define how we call depression. And I'm choosing depression just because it's an indication that it's a common indication for neuromodulation therapies. So there are 227 different combinations of this list of items that would lead to meeting criteria for depression. So obviously here we have a lot of heterogeneity, which has really compromised or limited our capacity to build good pathophysiological models for depression, right? We've been trying to figure out how do we map these signs and symptoms to the brain. And one could argue, or I would argue, that the problem for why we failed so badly is that the question itself is the wrong question to ask. If you look at this framework, you may think, well, psychiatry is different than the rest of medicine because that's not how we practice medicine. Or that's not how we think about medical conditions of the heart, of the liver, of the skin, of the lungs. But is it? Is it really that different? Well, it's different if you think of depression as a disease. But what's depression really? The way we define it is a constellation of signs and symptoms, right? It's not a disease, it's a clinical syndrome. And like all clinical syndromes, depression is heterogeneous. Like all clinical syndromes, depression it's defined strictly phenomenologically. And like all clinical syndromes, depression often encompasses many different diseases, many different disease mechanisms or pathophysiological mechanisms that can converge into a shared clinical presentation. So one example that I often give is you think of left heart failure as a clinical syndrome. There's some commonalities among all patients with left heart failure, right? So they'll tell you that they're short of breath, so that's a symptom. And if you examine them, you may hear crackles in the bases of their lungs, so that's a sign. But one can have left heart failure because of hypertension or valvular disease or arrhythmias or myocarditis or pericarditis. Those are very different diseases. They do converge into a shared heterogeneous presentation, but they're not the same disease, and they're not treated in the same way. And this is where we stand now in psychiatry primarily. We have very well-defined clinical syndromes, but if we manage to formulate them at the mechanistic level, we're going to be able to have better, more precise, and hopefully individualized treatment programs or treatment options. And the way to do that, where we stand today, is not to try to link the clinical syndrome to the biology, which is difficult to do for brain disorders, but for any sort of disorders. What we try to do is to dissect these clinical syndromes into score units of cognition, emotion, behavior, autonomic function. And then we're going to have a much better chance of linking our phenomenology with biology. So, and this is going to be a simplification, of course, but if you're thinking of the different aspects that define depression, it's an emotional disorder, so there's emotional symptoms. So we have negative affect, right? The depressed mood, which we can link to circuits that have a hub around the subgenal cingulate cortex, which we know is hyperactive in depression, which we know it can be both metabolically and physiologically. We know with healthy subjects who do not have a mood disorder, if you induce sadness, the activity goes up. This is also a target for DBS, deep brain stimulation, in depression. But beyond negative affect, in depression, you don't only have this excess in negative affect, you also have deficits in positive affect. These are issues like anhedonia, amotivation, which we used to think was part of a single continuum of negative affect on one side and positive affect on the other. Now we know these are two distinct continuums with distinct neuroanatomy, distinct neurophysiology, and distinct treatment requirements. So if you have problems with motivation or drive, this is a mid-sagittal cut, but if you were to move to the right or to the left, I will be pointing here to the nucleus accumbens, which is a critical node of the reward circuitry, which processes, when maladaptive, anhedonia, motivation, and symptoms of positive valence or positive affect. But again, depression as a syndrome is more than just emotional symptoms. It's a mood disorder, but there's more than mood to depression. That's why sadness and depression are not the same. We have problems with low energy. We have these ascending reticular pathways. We have problems with sleep and appetite, the more autonomic functions in hypothalamic nuclei. We have issues with cognition, attention, and executive function primarily. We have this cortical, subcortical, and this frontoparietal circuits that are processing the different constructs of executive function. We have rumination and guilt. These are issues. I'm pointing here to the posterior cingulate cortex, which is part of the full mode network, which processes the self-information. And when maladaptive, you have maladaptive processing of self. And this is what rumination, with at least the content of rumination is beyond just the form of the sticky and circular form of the thoughts. And finally, we have self-harm and suicide, which I would argue is a syndrome of itself, like depression or PTSD or schizophrenia. But this is a topic for another day. And we have a lot of empirical evidence that is pointing to the anterior cingulate as a key hub that carries a biological signal that is relevant to explain the severity of suicide and the presence of suicide, the aggressiveness of the means for attempting suicide, etc. So if we look at this graph, there's a couple of thoughts that come to mind. First is no wonder we failed at finding the circuit for depression, the brain region for depression, because that doesn't exist, right? This is a very diffuse picture, different hubs in the brain, and each one of these hubs is part of a network, are involved in processing some of these dynamics. The other thing that comes to mind is to see that while problems with motivation and drive and anhedonia are important for depression, they're not just important for depression, right? You have problems with motivation and anhedonia in depression, in schizophrenia, part of the negative symptoms, in traumatic brain injury, in some stages of Alzheimer's disease, in different forms of vascular or traumatic injuries to frontal lobes. So this is also this dimensional formulation of cases beyond helping you come up with better pathophysiological models for specific syndromes. It also sets the ground for transdiagnostic approaches to understanding the brain, but also transdiagnostic approaches for developing clinical tools, biomarkers, and new therapies. So our biological framework is going to be that of circuit neuroscience. Our clinical framework, this neuropsychiatric clinical framework, the one that we teach our fellows and our residents, is going to be that of dimensional formulations of cases. And sometimes when we explain this, it feels that we're trying to talk about something that is radically different the way we teach psychiatry or we practice psychiatry, but it's not. At the core, you will always have your history in your exam. That has to be 85% of the information that you need to formulate a case and come up with a treatment plan. And you will need your clinical tools to get a good history and to elicit a good exam, a psychiatric exam and a neurological exam. And then you'll need to come up with a case formulation and your tease apart your differential diagnosis. So you just do everything that we teach residents and fellows to do, and we've been doing it for 100 years. The only difference is that once you come up with this syndromal formulation, you don't just stop there. You go beyond that and you ask, well, of all the different combinations of symptoms, which are the ones that for this one individual are most important, the ones that are really compromising function. And if you're able to formulate the cases at this dimensional level, then you'll be able to formulate the case at the circuit level. Because if you tell me that a patient of all the different combinations has predominant anhedonia and motivation and these executive functions, I know the circuits that are processing those features. So I know the circuits that are primarily affected in this patient. And if I know the circuits, then I have a circuit formulation of the patient that allows for a circuit formulation of a treatment plan for that patient. And that's something that we will need, as we'll see, as you are trying to come up with treatment plans that involve devices, because devices, brain stimulation therapies, leverage the specificity of the anatomy and the physiology of individual brains. But to do that, to leverage that specificity of the anatomy and physiology, you need to be able to formulate the case at that circuit level. So this has led to a series of opinion papers, and I would say like a trend towards thinking about the circuit-based clinical practice, circuit-based formulation, this idea of being a circuit psychiatrist that Josh Gordon put up in his opinion paper, and also the understanding that if we're able to practice in this clinical space, anchor on circuits, that's the entryway, that's a helpful condition to start thinking about precision, to start thinking about solutions that are not just for like one-size-fits-all solutions, but are patient-specific solutions to both understand the case, but also to come up with therapies. All right, so again, the biological framework is going to be circuit neuroscience. The clinical framework is going to be this dimensional approach to case formulation. But there's also a technological framework as we're thinking about devices, right? So brain stimulation or neuromodulation therapies, it's important to understand that this is a group of technologies, not just treatments, right? These are technologies that we use to apply energy to the brain. And depending on how we do it, it can be a treatment, but it doesn't necessarily have to be a treatment. And there are many of such technologies, and we tend to describe them or characterize them in these three buckets. So we have the invasive or surgical techniques. There are things like deep brain stimulation. We're seeing an image here. There's more than DBS or deep brain stimulation. We have vagal nerve stimulation, epidural stimulation. Again, all these are techniques that require a surgery, the implantation of the stimulating electrodes in the brain or in neural tissues, sometimes in the brain, sometimes could be like the vagal nerve. And generally, this is like a pacemaker. It really, the technology developed from the cardiac pacemaker. There's a battery with a small chip. You implant it generally in the subclavicular region, and there's some electrodes that leave that battery. Only then, instead of going to the heart, which is a simple biological circuit, they go up to the brain or to the vagus nerve or to any other neural tissue. So invasive, surgical, of course, like all treatments that are more invasive and more surgical, they tend to be reserved for patients who are more refractory or who have failed or not tolerated other treatment options that are less invasive. And among these less invasive options, we have things like ECT, electroconvulsive therapy, or more exploratory magnetic seizure therapy. These are convulsive therapies. Right? They're not surgical, they don't require a scalpel, but they do require general anesthesia, and generally the induction of a seizure in a very controlled framework with a lot of supervision and monitoring. And these are, ECT is the very first treatment in psychiatry, is the very first device neuromodulation treatment as well, of course, and remains the gold standard for many difficult to treat conditions like treatment-resistant depression. We saw some cases of catatonia earlier for bipolar mania and depression, and for different forms of psychosis. So we have invasive, we have convulsive, and last but not least, we have the non-invasive. The non-invasive are not surgical, they don't require anesthesia, they're very safe, they tend to be outpatient ambulatory treatments, but we have more technologies now that are actually even home-based therapies, right? You can just do it at home. And because they're the safest and the better tolerated, they are the ones that have the largest number of indications and the largest pool of patients who actually could be candidates for these therapies. And these are the different indications that are actually approved in the US by the FDA. So you see that for deep brain stimulation, it was initially chronic pain, the very first indication, but that was eventually revoked. We use DBS mostly for movement disorders, so Parkinson's, essential tremor, dystonia. It's also approved for OCD, obsessive compulsive disorder, and the last approval was for epilepsy. We have VNS, vagal nerve stimulation. It's approved for epilepsy, for depression, more recently approved for stroke rehab of the upper extremity of the arm. And then we have TMS, which is approved for depression, for migraines, for OCD, and for smoking cessation. So there's a couple of things that are relevant here. One is that the conditions are not in psychiatry or in neurology or in physiatry. They are across all of these subspecialties, right? So these are tools that are not reserved for one or another clinical neuroscience subspecialty. And I think that's an important concept, because this shows how if you start thinking clinically at the circuit level, if you start formulating cases at the circuit level, which is the framework that is required for device therapies, the distinctions between what's neurological and what's psychiatry start fading away. And what you have is a set of circuits that have maladaptive properties, leading to maladaptive brain functions that can cross the motor, sensory, cognitive, affective, behavioral domains, right? And the tools they require to assess this patient and to treat them are the same, regardless of whether you had more basic training in neurology or in psychiatry or in physical medicine and rehabilitation or in pain medicine, different conditions that have indication for device neuromodulation therapies. So again, if you want like a very pragmatic evidence and prove that if you start thinking at the circuit level clinically, this brain health neuropsychiatry space starts becoming not just like a nice theoretical model, but an actual clinical reality. That requires, of course, changes in training, changes in practice, changes in policy, because it's not exactly how we've been practicing for the last 90, 100 years, but it's not radically different, and we're already doing it. And even if we saw different techniques, different indications, different subspecialties, there is a shared common framework for all of these device therapies, right? If you want to consider a treatment plan with DBS, with VNS, with ECT, with TMS, with focused ultrasound, with TDCS, there's always three things you need to know. A treatment plan for a patient, or you want to design a study. It also applies to that. You need to know what is the circuit that you want to change or modulate, right? That's going to be defined by the syndrome you're treating or the specific symptoms that the patient is presenting with. But there's more to that. You also need to know what is the target that will give you access to that circuit, right? Circuits by definition have many different nodes, but you don't need to change all the nodes at the same time because they're connected. So if you change one node, yes, you will change the physiology of that node, but you will also change what that node is doing to the other nodes. So you have some direct effects over that node, but transsynaptically, you're going to be changing the entire circuit, the dynamics of the circuit. And that's the goal, right? With brain stimulation, we don't want to change this blue node here or this red node here. We want to change the dynamics, the dialogue across the different nodes, because that's where the computations are happening, right? So there's these two more anatomical concepts that you need to know. You need to know the circuit you want to change. You need to know the target, which is a window that will give you access to that circuit. And then less anatomical and more physiological, you need to know the direction of modulation, right? Do you want to increase or decrease excitability? Do you want to increase or decrease connectivity? Do you want to increase an alpha rhythm, decrease a gamma rhythm? You name it. It depends on how you formulate the pathophysiology of the condition you're treating, or the response biomarker, the treatment target that you have identified, right? But always what you will want to do with device neuromodulation, with brain stimulation, is you want to change physiological dynamics, constraint in the anatomy of a circuit via a given target that is a window that gives you access to the physiology in that anatomy, right? So you need to know the circuit, you need to know the target, and you need to know the direction of modulation. And this whole space, again, the fact that you have this shared framework across devices and across subspecialties and across conditions and disorders has been leading to this idea of interventional psychiatry and neuromodulation as being a clinical space of its own, subspecialty of its own. And very recently, the last couple of years, we've had a couple of meetings going from Boston to Palo Alto, bringing people from all over the world really, to help us think about this process. And this is a paper that just came out a couple of weeks ago, 2 months ago, where we describe the proceedings of those meetings, and basically what would it take to actually define this subspecialty for neuromodulation and brain stimulation, right? And from this, we have a new society of brain stimulation, and there's a new application now to have a board certification in brain stimulation. That is an actually formal title, if you want, that certifies that you've been trained in that space, and that requires also specific definition of the knowledge that is required and the training that is required to be able to have expertise in this field. And what we're trying to do with this is not to hyper-regulate a space that is not regulated yet, is to provide a basis for more fellowships to be able to train more people with a more clear understanding of what the content that needs to be in these fellowships. So there's a number of educational activities that are being developed now so that we have training programs with training tools and lectures that are going to be shared across all fellowships. And this is not just, the process of certification is a very US-centric process, but the knowledge is not, of course, right? And some of these tools are being designed so that they can be used virtually, so that you could have access to some of these training tools from Colombia, from Spain, from Brazil, and from many different parts of the US. And one of the questions that came up from these meetings were the question of limits, right? And one of the limits is the limits of the tools. So it was pretty clear, if you think about interventional psychiatry, that the device neuromodulation tools, DBS, ECT, TMS, are part of this space of interventional psychiatry. But interventional psychiatry is the way it's being conceptualized in reality, in clinical practice, even in private practice or community settings, not just in academic hospitals like mine, is also that there's some novel procedure-based treatments that are advanced pharmacology, if you want, things like ketamine or esketamine, the use of IV neurosteroids or psychedelics, which are still not approved, but are starting to grow some evidence. These are pharmacological interventions, not device interventions, but they're different to traditional pharmacology. The main difference is that they require a procedure, right? And there's also other differences, that they are acting through different mechanisms of actions. These are treatments that have been developed bottom up. So they require certain understanding of the pathophysiology of depression, of the mechanism of action of these tools, and then leading to the identification of biomarkers, and then the pursuit of clinical trials that, based on that mechanistic information, develop a clinical tool. And the other thing that makes them different from traditional pharmacology is the time to response. These are rapid-acting treatments, right? We used to think that it takes 6 weeks to treat depression, and that was an inherent feature of the disorder we're treating, of the biology of depression. Well, now we know that that's not true. You can use ketamine in 1 or 2 sessions, so one day you can treat depression. Neurosteroids, mostly for postpartum depression, have shown also rapid action in after one infusion. Some of the evidence for psychedelics is also for rapid action, and we'll have, as I will describe later, TMS and ECT strategies that are also rapid-acting strategies. So where do we put the line? Is interventional psychiatry just brain stimulation therapy-based practice? Are we including IV ketamine? Are we including steroids? Are we including psychedelic-assisted psychotherapy as well? Well, I think that the question is still open, and in many ways it's being shaped in real life, that not just with academic debates. So we'll see where the final line is drawn. But beyond thinking of where the limits of the techniques that we use, a debate that we had in this process was the limits of the disorders we treat and the limits of the specialists who belong or who may want to be in this space. And I think that's an interesting or important debate also for the space of brain health, because you cannot effectively work in this space from just neurology, just psychiatry, just neurosurgery. It requires this multidisciplinary approach of both tools, but also of clinical know-how, right? So, what disorders? Well, we don't need to define it just theoretically. We are already seeing this list of disorders I showed you earlier that are crossing the line between psychiatry and neurology. So this is a space like brain health that is going to be crossing the lines between psychiatry and neurology. And therefore, the specialists will have to cross the line between psychiatry, neurology, neurosurgery, physiatrists, pain medicine doctors. This is going to be a dynamic process. I think it's important to not force it or restrain from a top-down perspective. We have to let the science and the clinical practice define these boundaries. But for now, as we define this subspecialty in brain stimulation, which is very akin to this idea of brain health, we were very open. And if you have a background in neurosurgery or neurology or psychiatry, you're welcome to join. You're welcome to train, and you're welcome to practice in this space. And last but not least, how do we call it? Is it interventional psychiatry? Well, some of the neurologists felt that fell to psychiatrists, and it's true. But there's also people coming to the space from movement disorders, right? Because they learn a lot of DBS, or from epilepsy because they learn a lot of VNS. So we ended up calling it this special brain stimulation, with understanding that there will be subspecialties or other subspecialties that are converging with it. So, you may train in movement disorders and have a foot in interventional or brain stimulation, or you may train in epilepsy, or you may train in interventional psychiatry and have a foot in brain stimulation, but maybe the things you do interventional psychiatry that are more, advanced pharmacology may not be core to brain stimulation, but still important for clinical practice as an interventional psychiatrist. So in summary, for this first part, we have this triple paradigm where we have the biological framework, and again, that's a circuit neuroscience approach to defining pathophysiology, to identifying biomarkers, to developing treatments. You have a clinical framework, which is this dimensional-based approach to case formulation and treatment planning. And last, you have a technological framework. If you're thinking about brain stimulation, where you have invasive, convulsive, and non-invasive techniques, right? So again, that's the triple paradigm for interventional neuropsychiatry, putting together both the neuropsychiatric component and the interventional component. And it's going to be important to think about precision, right? So let's discuss precision. How do we develop treatments in neuromodulation? Well, the assumption here is that any brain function or any brain condition that you can define at the circuit level is a potential indication for a neuromodulation therapy. And to define a problem at the circuit level, there's 3 levels of analysis. You have to understand the anatomy of the circuit. You have to understand the physiology, the dynamics within that anatomy, and you have to understand the behavior that is the product of, if you want, those computations. So there's the where, there's the how, and there's the what that you'll be able to understand. But as long as you can formulate a case, a condition at the circuit level, then it's a potential indication. Okay, it's a potential indication for brain stimulation. So that requires a process by which we define pathophysiology at this level. But again, to develop treatments from a bottom-up perspective, it's not enough to just understand the pathophysiology. You have to identify biomarkers, right? And there's different types of biomarkers. You have disease biomarkers that separate if you have disease A versus B, severity biomarkers. You have predictors biomarkers that tell you something about the futures. But the ones that are most important for treatment development are the response biomarkers, right? Response biomarkers are dynamic biological signatures that by definition are dynamic, so they change. But when they change biologically, they carry with them the variance of clinical severity, right? So basically, it's a biological signature that changes, and when it changes, you see that the clinical severity changes with it. So we need to understand the signatures in order to develop treatments. And particularly, we need to understand and to develop treatments that enter this precision medicine space, in this case, precision psychiatry or if we want to be more even narrow, precision neuromodulation, right? So how do we develop patient-centric therapies? Well, there's 3 levels of analysis, or there will be 3 approaches, right? We either develop precision by controlling the anatomy, so the where, and there's some examples here, for example, of MRI-guided TMS. You can control the when or the how, so trying to individualize based on measures of the physiology of individual subjects. So examples of this could be EEG-guided TMS, where we're trying to apply TMS, align or synchronize with specific oscillations. And last, you can control the what, or the mental state, right? So we know that most of these treatments are state dependent. So the patterns of stimulations are going to be important, but what's happening in the brain when it's receiving that stimulation is also important. So being able to control that, for example, with combination therapies, where you're doing behavioral therapies, sometimes using virtual reality, sometimes using just more traditional behavioral interventions that will set the mental state in one control, predetermined state, and in that case, that's when you're going to be applying the stimulation. All right, so I actually wanted to give me 5 more minutes, right? So I'll try to walk you through some examples to not make it too theoretical, right? So I wanted to show you an example of how do we individualize based on anatomy and physiology and state dependency. So anatomy is going to be very important with brain stimulation. You have to know, for example, with TMS, where you place the TMS coil, or with DBS, where you place the electrode. And if you look at the different indications that are approved for TMS, we have the left dorsolateral prefrontal cortex for depression, we have the midline, the dorsomedial prefrontal cortex for OCD, the occipital pole for migraines, the ventrolateral, bilaterally, prefrontal cortex going all the way to the insula for smoking cessation. So these are very different targets because these are very different conditions that have different pathophysiological mechanisms that engage different circuits. So you need to keep that in mind. So knowing the anatomy is important, and we have tools today like neuronavigations that are basically stereotactic systems that allow us to, know precisely where we are in the brain. Right? I generally say that in TMS specifically, one of the good things is that it's non-invasive, but one of the bad things is that it's non-invasive, and that's because you have a lot of precision, but you're not seeing the brain, you're seeing the scalp, right? So you need tools like neuronavigation that will give you access to understanding where you are in the brain, right? So the way this works generally is you have a brain imaging of any modality of that one subject that you capture one day before, several days before, several weeks before, and then you upload it to this computer, and then you can register the head of your patient with the MRI, and then as you're moving around the head of the subject or your patient, if you're looking at this stereotactic screen, then you know precisely where you are in the anatomy of that one subject. And for depression, the way this has been developed is by defining the subgenal cingulate, which, as I mentioned earlier, we know is a very important hub of the circuitry that's involved in mood disorders and particularly depression. And we can do functional connectivity and define which is the target, the window that optimally gives me access to subgenal cingulate for that one subject. And that's important because this anatomy is going to be very different from subject to subject. So if you're in the wrong target, you may not access the right circuit, and you may not have the clinical effect that you want. So once you have the right target, then you can use stereotaxis and do precision neuromodulation, again, defining the target specifically for each one for every patient. And this has led to a number of studies, but I'll just focus on this one. This was the SANE trial by our colleagues at Stanford that developed this accelerated protocol of TMS. So there's two components to this SANE protocol. One is there's a massive dose of TMS, right? The way we do TMS, historically, the way we've done it, we do it today, is we give one session every day, Monday through Friday, for 6 weeks, sometimes 4, sometimes more than 6 weeks. But what these colleagues tested here is a protocol where you give 10 sessions of TMS in one day, and you do this 5 days back to back. So it's a massive dose of TMS. But in addition to this massive dose of TMS, they're using fMRI guidance to define that target, right? So there's two components, the massive dose and the precision of the imaging. And the clinical trials show numbers that we're not used to, right? These are treatment-resistant depression patients, very sick. Some of them fail ECT. And in just 5 days, we see an 85% response rate, meaning you get at least 50% better, and a 78% remission rate. These are not numbers that we're used to in treatment-resistant depression. So I think they're causing or generating a fair amount of healthy skepticism. But there have been several trials from this group, and this is starting to be replicated by other groups. We still want larger trials, but these numbers are very impressive, leading to FDA clearance by the FDA in 2022. So this is the first treatment approved in psychiatry that has a biomarker embedded into, right? So it's a biomarker-driven treatment for depression that's been approved and that now can be used in clinical practice in a US context. And this is bringing us again to the space of rapid treatments for depression, right? ECT historically has been a pretty rapid treatment, ketamine or steroids, psychedelics, and now fMRI-guided TMS. So we have lots of options, but again, the question here is who should get what when, right? And for this, we need to develop these algorithms, oftentimes based on AI tools that help us identify of all these different options, Mr. Smith should get treatment A, treatment B, or treatment C, based on their, again, demographic, clinical features, biological features. And I'll finish by giving you an example that is moving away from anatomy, but it's trying to focus more on physiology. And it's moving from depression to Alzheimer's disease. So we've historically thought of Alzheimer's disease as at the molecular and cellular level. Remember that first graph at the very beginning where we had this inverted pyramid? So we thought of a pathology or condition where you basically have abnormal amyloid and tau that leads to neuroinflammation, that leads to neurodegeneration, right? So this still is the predominant model, although I think the outcomes from recent antibody therapies are starting to question this framework because we can very effectively clear amyloid, yet we have very limited impact on clinical severity. But because, again, our approach to this was molecular and cellular, the therapies that came from this approach were molecular and cellular, so pharmacology and immunotherapy. There's been some evidence more recently thinking about Alzheimer's disease at a different level, so at a higher level in that inverted pyramid, not at the cellular and molecular level, but at the physiological level, thinking about specific patterns of oscillations that are maladaptive and characteristics of Alzheimer's disease. And because, again, our level of analysis here is not cellular and molecular, but it's physiological, this leads to treatment options, treatment developments that are physiological in nature, right? Things like neuromodulation. So let's rapidly walk through this. So we have different types of brain waves that have different names depending on the frequency and how slow or rapid they are. Gamma waves are known to be important for cognition, and they've been described to be low in Alzheimer's, particularly the 40 hertz rhythm. So the hypothesis here is that if we target these 40 hertz rhythms that is maladaptive in Alzheimer's disease, that's our response biomarker, we could potentially develop new treatments for Alzheimer's disease. So there's been work done by our colleagues at Li Wei Tsai at MIT, across the bridge from where I work, that show that in rodent models of Alzheimer's disease, you have deficits of these oscillations, of these gamma oscillations. And she was able to apply sensory stimulation, so visual and auditory stimulation, so not brain stimulation or electrical stimulation, at this 40 hertz rhythm, trying to kind of recover these abnormal 40 hertz rhythms in this rodents model of Alzheimer's disease. And what she observed was that, first of all, she could recover or improve these deficits in gamma rhythms, which I think it was not surprising, but that makes more sense. Like you're applying 40 hertz rhythm and then you improve the physiology of the oscillations. What was very interesting, though, is that she was able to improve the memory deficits of these rodent models, which is more relevant from a clinical perspective. But what no one was expecting was that by applying this stimulation, she was able to clear amyloid and tau. She was able to reduce neuroinflammatory markers, and she was able to stop a neurodegenerative process. So the link between the physiology and the molecular and cellular pathology of Alzheimer's disease is still not fully clear. We're starting to figure out in rodent models, but of course we do not want to just figure this out in rodent models. We want to figure out in patients, human patients, and that evidence led to a trial where they tried to do the very same thing, right? They applied visual stimulation and auditory stimulations at 40 hertz in patients with Alzheimer's disease. And there's been a series of trials that I would say surprisingly, they seem to translate the rodent data into human data quite well. So we're seeing that when we applied these genus, so gamma and tremin using sensory stimulation, that's how they call it, we can improve the deficits in gamma, so we have impact on physiology. We can improve memory, so we have clinical symptomatic impact, but also in humans, we see that we can reduce the trends of volumetric changes that we would observe in neurodegenerative dementias like Alzheimer's, and using both PET and lumbar puncture CSF biomarker analysis, we see that there are improvements in the amyloid and biomarkers. Some evidence on tau, but so far it predominantly seems to be evidence on the amyloid deposition. So again, this is a very exciting space that is developing with the idea that this may not just be a symptomatic treatment that is improving physiology and memory, but if it's actually doing this by changing the trends in volumetric decreases and being able to clear amyloid, then it may be a disease-modifying treatment, like we've been considering the antibody treatments, only that this treatment may actually have clinical and cognitive impact, while so far the evidence that we have with the antibody treatments that we're using, I also prescribe them, has more limited benefit. And of course, if you want to go from this space to the precision space, you want to be able to define the intervention for the specificity of that one patient. So you want to go from using auditory and visual stimulation to electrical stimulation, right? At the end of the day, what we want to change is these oscillations in the brain. These are electrical patterns. So why use visual and auditory energy if you could just use electrical energy to change electrical phenomena, right? And if we can, to do it at home. So let me go straight to this. So we have a tool called transcranial alternating current stimulation. That's we were discussing yesterday at some point. It's a very small, very cheap, extremely safe device neuromodulation tool that can be done at home. And depending on the current patterns that we applied, it can have different effects. We can apply direct current or oscillatory current. So when we apply oscillatory current, we can actually change physiological oscillations. So again, if we have in Alzheimer's low gamma waves at the 40 hertz rhythm, we could apply ACS, TACS at 40 hertz and try to use that as a way to recover stimulation. And the traditional way to do this would be you apply 40 hertz stimulation to the brain of a subject, then you measure the impact on physiology and in clinical practice, in clinical status. But this is blind to what's going on in the brain. You're not trying to observe what's going on in the brain of that one patient. You're just blindly applying this 40 hertz rhythm, right? So this is a one size fits all. It's not individualized. That's how we traditionally practice medicine, but not how we want to do it in a precision context, right? For precision, we want to start thinking about closed loop systems. So I'm measuring the physiology of that patient. I'm measuring the 40 hertz rhythms, and I'm going to apply my stimulation as a function of the biomarker that I'm measuring. In this case, this is a tool that we've developed and that we're now testing in patients, where we're trying to apply stimulation that is synchronized with these 40 hertz rhythms that are going on in the brain of patients as a way of, individualizing the frequency. Again, there's nothing magic about 40 hertz. For some patients, it's going to be 38 hertz. For some, it's going to be 43 hertz. So we individualize the actual frequency and also the timing so that we synchronize the oscillations of the stimulation with the oscillations in the brain. And this is the last example for how we could use precision precision neuromodulation, not by focusing on the anatomy, but by focusing on the physiology. And we'll wrap it up here. Just an example of how you could use VR to treat it, but we'll wrap it up here. So as a summary, if we think about precision neuropsychiatric neuromodulation, there's this idea of being patient-specific and developing treatments that are specific for patients. So we're trying to address the clinical and biological heterogeneity. We require this biomarker-informed approach to developing treatments. Serendipity is not good anymore, or it's not that helpful. And again, in the specific case of neuromodulation, we want to focus on circuits. And that requires understanding anatomy, physiology, and behavior as a way to understand pathophysiology, develop biomarkers, and develop novel treatments. In the specific case of developing individualized therapy, again, this is anatomy, physiology, and behavior. We talk about individualized MRI-guided TMS. We talk about closed-loop EEG-guided TACS. And we didn't talk as much about using combined therapies like cognitive rehabilitations and TMS and TACS as a way of individualizing therapies. So we'll wrap it up here. Thank you so much. And we'll take questions.
Thank you, Dr. Catalano. We are currently a bit off schedule, so we have time for just one very small question. Does anyone have a question?
What do you think about, for example, using RDocs, the research domain criteria, in the approaches like this, like particularly in poor countries, or like to the development of precision psychiatry in places where we don't have this time to do research?
Right. So, so the question is, RDoC is the research domain criteria, is a system developed by the National Institute of Mental Health in the US to facilitate research. It's a research domain criteria, and in a way, it's one of these dimensional formulations. It has a matrix with different domains: negative valence emotions, positive valence, there's cognition, there's somatosensory, there's different functions, and what's trying is for each one of these dimensions. There's a cellular, there's a molecular, there's a behavioral, there's a circuit, there's an anatomical region. So this is one example of these dimensional approaches. One is very valid, core to many of the research we do. And one, while it's research domain criteria, I think you could think of it as like a clinical domain criteria, because it's not just valid to do research, it's also helpful to clinical practice. RDoC itself is not expensive, or these dimensional approaches are not necessarily expensive, right? So if you have the capacity to do paper pencil assessments of patients, beyond using the Hamilton or the MADRS that are syndromal measures, if you can measure motivation, if you can measure anhedonia, if you can measure executive function, if you can measure affect lability or regulation, these are tools that are paper pencil. They're very cheap, totally implementable in a clinical and research setting with less resources. And some of these tools that I show, so things like fMRI-guided TMS is much more expensive and resource consuming. But TACS, for example, or TDCS, these are devices that are very cheap to manufacture. They're very small, they're very, very safe. So it's a very good entry point to doing research in context with more limited resources, but also to implementing therapies, even to scale those therapies at the population level. So tools like this EEG-guided TACS that we develop very consciously, we're thinking about scale, and we're thinking about cost. We're thinking about safety and efficacy, of course, because if it's not safe and effective, you don't have a treatment. But we're thinking about developing this strategy as something that could be easily scalable with low cost. And this has implications also for environments with more resources, right? So we develop a treatment that is low cost, safe, and effective. It can be done at home. Even if in an environment where you have more resources, it's going to be easier for insurance companies to agree to pay for it if it's cheap than if it's expensive, or for patients to decide that they're going to buy it themselves, right? So again, while not all of these tools, particularly the most expensive and high tech, could be easily applicable to a more limited resource setting component, many of them could be done without a problem.
Thank you again, Dr. Juan.
Up next, we welcome Dr. Narcis Cardoner, who will present on psychiatry and neuroscience in Europe. Before we begin, I would like to remember the people who register to the workshop to please go out of the auditorium at 11 so you can attend to the workshop. Dr. Narcis Cardoner, welcome. He is a psychiatrist at the Hospital Universitari Park Tuali in Sabadell, an associate professor of psychiatry at the Universidad Autónoma de Barcelona. He holds a medical degree from the same university and a PhD in medicine and surgery from the University of Barcelona. He's a clinical research work, and his research work focuses on affective and anxiety disorders, particularly treatment-resistant cases, using neuroimaging techniques to identify neurobiological markers. Please, Dr. Cardoner, welcome.
Okay. Thank you very much for this kind introduction. Almost all is true, not all, but now I'm in another hospital, but thank you very much. Thank you very much. It's a great Congress. Okay. Okay, thank you. Y gracias a todos. Gracias a José Manuel, a Gabriel, a Ivonne por esta cálida acogida. Es fantástico estar aquí. Gracias a Nano, no sé si está por aquí Nano, el doctor Santa María, que realmente casi 10 años que nos vimos en Barcelona. Realmente lo que estáis haciendo aquí es increíble, ¿no? Y bueno, soy realmente muy contento y yo quiero realmente pues daros la enhorabuena por todo, ¿no? Y también quiero agradecerle a Nano que me diera este tema, ¿no? Psiquiatría y neurociencia en Europa, porque me ha sacado completamente de mi área de confort, ¿no? Y digo, ¿pero qué voy a decir de todo esto? La verdad es que fui procrastinando, digo, ¿qué diré? Tengo que pensar qué tengo que decir aquí. Y llegué aquí, tampoco sabía qué iba a decir. Y realmente he ido construyendo, os voy a decir la verdad, he ido construyendo toda la presentación en base a lo que he estado oyendo aquí en el Congreso, porque el Congreso es fantástico y salen grandes ideas. Y también en el postcongreso, porque el postcongreso es mucho mejor, ¿no? Y lo que es la sobremesa es un ámbito que surgen unas ideas maravillosas, ¿no? Y a partir de aquí he ido intentando construir esta presentación, ¿no? Estos son mis conflictos de interés. Y ese sería un poco el sumario, ¿no? El esquema que voy a seguir. Hemos estado hablando mucho del presente y del futuro. Me vais a dejar que me vaya un poco al pasado, que haga una visión al pasado, porque yo creo que nos hace entender cómo estamos ahora mucho mejor y entender cómo la psiquiatría, yo creo que a nivel mundial, pero en Europa, volvió a encontrarse con la neurociencia. ¿Cómo está Europa actualmente? Quiero daros también como ejemplo España, cómo estamos trabajando en este ámbito. Y por último, pues como un ejemplo que estamos haciendo ahora en el hospital donde estoy, en el hospital de San Pau. Mirar, un poco lo que os decía, es interesante volver atrás, ¿no? Y dar una visión. Y es cierto que en Europa, yo creo que se gestó el primer encuentro entre lo que sería la neurociencia y la psiquiatría. Y Greisinger fue el primero que dijo algo que parece obvio, aunque a lo mejor no es tanto, ¿no? Dijo, los trastornos mentales son enfermedades del cerebro. Y es el primero que lo dijo. También tenemos que agradecer, por ejemplo, el esfuerzo de Meiner, que fue un psiquiatra y un neurólogo, que insistió en encontrar una correlación entre alteraciones estructurales y problemas de salud mental, problemas psiquiátricos. con poco éxito. Y no puedo tampoco evitar la figura de referencia, ¿no?, en España, que es Ramón y Cajal. Él desarrolló la teoría neuronal y también nos permitió empezar a entender el cerebro como circuitos, ¿no? Ahora estamos entendiendo el cerebro como circuitos y estamos empezando a hablar, por ejemplo, de las enfermedades psiquiátricas como patologías de circuitos. También tenemos que distinguir y agradecer el esfuerzo de Kraepelin, que empezó a clasificar por primera vez las enfermedades psiquiátricas. Le debemos a Kraepelin las clasificaciones actuales con sus ventajas y sus inconvenientes, ¿no? El DSM, el ICD, son neocrepelinianos. Y tenemos también que, por ejemplo, destacar figuras como un psiquiatra como fue Alois Alzheimer, que en su camino se encontró con una paciente, Auguste Deter, una paciente que con 55 años, mi edad, desarrolló un cuadro de deterioro cognitivo muy, muy grave, con sintomatología psicótica muy atípica en ese contexto. Y él siguió a esta paciente y describió por primera vez una enfermedad. Él tuvo la suerte de poder establecer un correlato, ¿no?, entre una alteración conductual y una alteración estructural, ¿no?, y acuñó la enfermedad de Alzheimer, cosa que no tuvieron la misma suerte otros científicos que estudiaron, pues, no sé, la esquizofrenia o el trastorno bipolar o el TOC. Y entonces en definitiva se empezó a acuñar un concepto que por lo menos en la clínica en España se utiliza todavía, que es lo funcional. Este paciente es funcional. ¿Por qué? Porque no encontraban una alteración estructural y atribuían algo que era la función del cerebro que estaba alterada y que no podíamos medir. En ese entonces no podíamos medir, ahora podemos medir. Y bueno, ¿y qué ocurrió? Que se olvidó un poco el cerebro y se empezó a hablar de la mente más. Y además ocurrió algo muy importante, ¿no? Toda la eclosión del psicoanálisis, que de alguna forma dividió Europa, o dividió la psiquiatría en Europa, con una gran ascendencia, ¿no?, en muchos países europeos del psicoanálisis. Además, una ascendencia que luego también se trasladó, se transportó, o sea, que se exportó a Latinoamérica, ¿no? Argentina, Chile, Colombia, México, presentaban una gran ascendencia, una gran impronta todo el modelo psicoanalítico. Y sí que es cierto que quedaban algunos reductos, sobre todo en países como Alemania, en los cuales se mantenía esa idea de la psiquiatría más biológica, más vinculada a las neurociencias. Hay que destacar, por ejemplo, a Kurt Schneider, con toda su descripción fenomenológica de la esquizofrenia. O, por ejemplo, la serendipia que llevó al descubrimiento de los primeros fármacos, ¿no? Eso también se hizo en Europa, ¿no? La clorpromacina, el primer antipsicótico, se desarrolló en Francia. O el primer antidepresivo, que también por serendipia se descubrió en Suiza, ¿no? Ocurrió allí. O sea que a pesar, ¿no?, de esa mayor prevalencia de un modelo más basado en el psicoanálisis, existían algunos reductos en los cuales se estaba, de alguna forma, desarrollando ese vínculo, esa relación entre la neurociencia y la psiquiatría. Y es interesante ver cómo progresivamente la importancia de la neurociencia fue creciendo a partir de los años 80, ¿no? Y ahora, pues, mirad, por ejemplo, es una gráfica que he construido a partir de las referencias en literatura europea y cómo va creciendo el número de referencias que tienen que ver con neurociencia y se va, aunque se mantiene, se va reduciendo la relevancia, la importancia del psicoanálisis, ¿no? En definitiva, ¿qué ocurrió? Bueno, pues fundamentalmente ocurre algo tan importante como que hay una revolución tecnológica, ¿no? De repente tenemos la neuroimagen, tenemos técnicas que permiten trascender, superar ese límite, ¿no? No tenemos por qué hacer una necropsia, no tenemos por qué analizar cerebros de forma individual, sino que podemos evaluar muestras amplias de pacientes de forma secuencial y de forma longitudinal. Podemos ver qué pasa si hacemos una intervención. Y eso es algo que cambia, ¿no? Y que cambia las posibilidades y favorece esa introducción, ¿no?, de la neurociencia en la psiquiatría. También la genética, todas las ómicas tienen ese papel. O también todo el desarrollo de la neurociencia cognitiva. O, por ejemplo, también toda la psiquiatría computacional, que nos está permitiendo llevar a conclusiones que antes era imposible pensar, ¿no? Y eso probablemente es un factor que ha permitido, ¿no?, ese cambio significativo. Es cierto que en ese contexto, y si me pongo a hablar de Europa, pues Europa salió partiendo de ese liderazgo, ¿no?, en la neurociencia y en la psiquiatría. Aparece en ese contexto, en esta revolución, ¿no?, que tiene que ver con la neurociencia actual, por detrás, por ejemplo, de un gigante que sería los Estados Unidos. Los Estados Unidos realmente toman ese liderazgo y desarrollan de una forma mucho más significativa, mucho más marcada este aspecto, ¿no? Y hemos hablado, pues, desde el DSM, probablemente unos tipos de clasificaciones que intentaban comunicarnos, ¿no?, entre todos los psiquiatras a nivel mundial y poder establecer patrones comunes, ¿no?, delante de los pacientes. Una inversión enorme en ciencia, una inversión que espero que continúe, ¿no?, por el bien de la ciencia, ¿no? Hemos hablado antes de los AirDoc, cómo cambian un poco el panorama, cómo nos enfrentamos a la complejidad de la conducta. Realmente esa importancia, ¿no?, y esa relevancia de Estados Unidos hace que Europa esté siempre como, me da la sensación, ¿no?, siempre está como a 2 pasos por detrás en muchos aspectos, ¿no? Pero realmente sí que es verdad que actualmente podemos empezar a estar optimistas, ¿no?, por todo lo que estamos haciendo en Europa en este contexto. ¿Y por qué es importante esta relación, ¿no? Fundamentalmente yo creo que es importante porque realmente la neurociencia nos permite, es más integradora. No puedo entender, pensar que cuando estamos hablando de neurociencia, cuando estamos hablando de salud cerebral o brain health, estemos planteando algo reduccionista. Al revés, es integrador. Hemos visto miles de ejemplos, muchos ejemplos en este congreso, donde cómo se integra, ¿no?, la parte clínica, la parte biológica, la parte social, la parte psicológica, gracias a modelos que parten de la neurociencia. Además, es también importante, yo creo que es importante ese encuentro entre la neurociencia y la psiquiatría, porque de alguna forma permite ser similar o tener un patrón similar a otras especialidades. La medicina tiene que estar basada en la evidencia y la psiquiatría tiene que estar basada en la evidencia, ¿no? El marco de la neurociencia nos permite estar basados en evidencia. Además, es una forma de equilibrar, de establecer en el ámbito de la salud un modelo similar, ¿no?, e integrar esa formación. La mayor parte de entidades están integrando en los currículums científicos la neurociencia como un patrón central, ¿no?, como un patrón estándar, ¿no?, en ese sentido. Pero todo esto, en definitiva, tiene que repercutir sobre el paciente, ¿no? Todas estas ventajas tienen que permitir una aproximación centrada en el paciente que nos permita llegar a lo que Joan comentaba, ¿no?, de esa psiquiatría de precisión o esa psiquiatría personalizada, que es lo que realmente estamos buscando, ¿no? Y el contexto de la neurociencia es lo que nos lo tiene que permitir. ¿Qué otros agentes, no? Os comentaba que uno de los agentes que han propiciado este cambio, ese reencuentro entre la psiquiatría y la neurociencia, era todo el desarrollo tecnológico, y es evidente, ¿no? Pero es cierto que hay otros aspectos. Uno que ya ha surgido aquí, esa limitación que suponen esta aproximación sindrómica que tiene que ver pues, con los criterios diagnósticos del DSM y que realmente estamos empezando a abandonar, ¿no? Y incluyendo los RDoC, que la traducción europea es el ROAMER, que apareció 2 o 3 años después, pero que mantiene la misma filosofía, permite un cambio evolutivo a nivel científico. También un aspecto esencial que también puede ser un agente movilizador es las necesidades que tenemos en psiquiatría. Las asignaturas pendientes de la psiquiatría, partiendo, por ejemplo, de la prevención en psiquiatría, partiendo del diagnóstico precoz en psiquiatría y también del tratamiento de aquellas formas más resistentes de esos pacientes que no responden a los tratamientos habituales, ¿no? Esas necesidades no cubiertas también han sido un motor, un agente movilizador de este cambio. Y un aspecto que para mí también es esencial es que la neurociencia nos permite hacer frente a un aspecto que también es muy relevante, que es el estigma. El estigma puede de alguna forma vencerse con evidencia, ¿no? Si podemos superar la subjetividad que muchas veces tiene que ver con las enfermedades mentales con aspectos más objetivos, podemos conseguir superar un aspecto que es algo caudal, ¿no? Que tenemos que conseguir superar, que es el estigma en salud mental y en psiquiatría. Y bueno, ¿por qué en Europa este encuentro entre la neurociencia y la psiquiatría pues puede ser un entorno adecuado? Por un aspecto, ¿no? Hemos hablado también varias veces aquí de la situación que tiene que ver con el sistema sanitario, ¿no? Europa tiene un sistema de salud universal. Todos los europeos tienen un derecho a recibir asistencia sanitaria. Todas las estrategias que parten del horizonte Europa, ¿no? Que acabó la primera parte en el 2020, que continúa hasta el 2027, se alinean perfectamente con esas necesidades, ¿no? La investigación y la innovación tiene que ver también con mejorar la salud de los europeos, ¿no? Y la salud mental de los europeos. Europa es un conglomerado de diferentes poblaciones. Tenemos la ventaja de esa diversidad y también tenemos la ventaja de tener registros muy amplios, ¿no? Están como referencia los registros escandinavos de cortes enormes de pacientes, ¿no? También el biobank de UK. Todo eso nos dan oportunidades de crecimiento, pero también condicionan barreras, ¿no? Hay una heterogeneidad de sistemas, no se aplican los mismos procedimientos, no se aplican las mismas guías, y todos esos son aspectos que son retos que tenemos también que superar, ¿no? Conseguir un marco, un entorno mucho más homogéneo, y existe una serie de estrategias que están permitiendo dar ese paso también. Mirar, por ejemplo, yo os hablaba del Horizon. Horizon es todo el sistema de financiación, de innovación y de investigación en Europa. Son becas muy, muy competitivas, pero que requieren un trabajo colaborativo de diferentes países a lo largo de Europa, ¿no? Un aspecto también de esta categoría sería el Human Brain Project, ¿no? Que acabó en el 2023, pero que ahora continúa con el eBrains y que realmente es una oportunidad muy, 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 muy interesante para conocer, para profundizar en el cerebro, ¿no? Otras propuestas, ¿no? Que parten de Europa, como el EBRA, como los Joint Programs, como el ERA-Net Neuron, se alinean para conseguir innovación y mejorar la investigación en áreas vinculadas, por ejemplo, a las neurociencias y a la salud mental. Realmente estamos en un contexto, aunque muy competitivo, muy exigente, que permite el desarrollo y un desarrollo global, ¿no? Un desarrollo europeo, ¿no? En el sentido de que propicia ese trabajo más colaborativo entre los diferentes países de Europa. Realmente una de las líneas, ¿no? de mayor relevancia ha sido la salud cerebral. Europa propicia este concepto que intenta englobar este congreso, ¿no? La salud cerebral. 1 de cada 3 personas sufrirá un problema neurológico o psiquiátrico a lo largo de su vida. Realmente es algo que tenemos que intentar prever y tenemos que intentar afrontar de una forma contundente. Os comentaba, ¿no?, el Human Brain Project, ¿no? Realmente ha sido un proyecto relevante en el que se ha focalizado muchísimos esfuerzos en el cerebro y que ahora continúa con el eBrains, en el cual realmente estamos depositando también mucho interés en el sentido de que puede ser una herramienta que permita modificar y cambiar muchos aspectos vinculados con la psiquiatría y los problemas neuropsiquiátricos. También destacaría el papel que están haciendo diferentes asociaciones científicas en Europa, ¿no? La CNP, la IAP, la FENS, probablemente se reflejan, ¿no?, en sus equivalentes americanas, ¿no?, pero realmente tienen un papel muy importante, tanto a nivel académico como a nivel de investigación, como a nivel formativo en Europa. Y realmente existen múltiples grupos de trabajo que están haciendo una labor importante en ese sentido de integrar, de poder conseguir realizar una actividad conjunta, colaborativa en todos los países europeos. Otro aspecto que para mí es muy determinante es toda la actividad de consorcios europeos científicos, ¿no? Muchos países, muchos laboratorios europeos están llevando un papel de lideraje, por ejemplo, en ámbitos como el ENIGMA, como el Psychiatric Genomics Consortium, como consortios específicos que están desarrollándose, por ejemplo, el GEMRIC, ¿no?, en el que participa Joan, que intenta evaluar aspectos correlatos de neuroimagen en técnicas como la terapia electroconvulsiva o otras técnicas de neuromodulación. Otras iniciativas que intentan establecer, por ejemplo, marcadores o biomarcadores genéticos que intentan prever la respuesta a diferentes estrategias terapéuticas y que aglutinan diferentes laboratorios a nivel europeo para intentar incrementar el tamaño de las muestras y, por tanto, incrementar el tamaño de la evidencia que podemos obtener de este entorno. O sea, realmente, en investigación y en neurociencia, el trabajo colaborativo es esencial, ¿no? Destacaba, por ejemplo, todo el complejo de Enigma, ¿no? A pesar de que es una iniciativa de Estados Unidos, ¿no?, me parece que de la Universidad de South California, realmente la densidad de grupos y que son grupos que lideran diferentes ámbitos como el OCD, como la depresión en Europa es altísima. España también participa en muchos de estos aspectos de una forma significativa. Realmente todo este movimiento de consorcios es esencial y es muy importante mantenerlo. Dejadme hablar un poquito también de España, ¿no? En España se establece un centro de investigación biomédica en red, que se llaman CIBER, y hay un CIBER específico de salud mental. Dentro de este CIBER específico de salud mental tenemos diferentes iniciativas de investigación que parten desde la depresión, el suicidio, la esquizofrenia, el trastorno bipolar, innovaciones terapéuticas, psiquiatría infanto-juvenil y psiquiatría psicosomática y trastornos de ansiedad. Realmente estos son 23 grupos en toda España, distribuidos de esta forma. Aquí, por ejemplo, en la rivalidad Barcelona-Madrid, Barcelona está ganando 10-6, claramente, más allá del fútbol. 10 grupos en Barcelona, 6 en Madrid, 2 en el País Vasco, 1 en Asturias, 2 en Andalucía, 2 en Valencia, que intentan de alguna forma también, de forma colaborativa, establecer proyectos de investigación específicos en estas áreas de interés desde una perspectiva nacional, ¿no? Realmente, Diversam también participa como un líder también a nivel europeo en diferentes consorcios, ¿no? Y es representativo de toda la actividad científica en España. Os quería también un poco ya, porque me han pedido que sea breve, hablar un poco de lo que estamos haciendo en São Paulo, ¿no? Yo ahora, hace 3 años que llegué a São Paulo y he empezado casi de cero. Por tanto, os voy a explicar la mayor parte de estudios que estamos empezando, que no tenemos todavía resultados, pero que, bueno, que van en la línea de lo que hemos estado hablando aquí, ¿no? Hay un ámbito muy interesante que os comentaba. Es muy rico la información que tenemos en las bases de datos europeas, ¿no? Nos permiten responder preguntas muy interesantes. En este sentido, por ejemplo, estamos trabajando de forma colaborativa con diferentes centros a nivel europeo con bases de datos escandinavas. Sabéis que los escandinavos lo miden todo, son fantásticos en ese sentido, todo lo tienen absolutamente registrado y nos permiten plantear preguntas importantes que probablemente pueden tener una repercusión en cómo tenemos que afrontar aspectos de investigación o de desarrollo en salud mental. Por ejemplo, estamos haciendo estudios de en qué medida los ensayos clínicos están representando la práctica real. Y nos encontramos que prácticamente el 80% de los pacientes, por ejemplo, con esquizofrenia o el 50% de los pacientes con depresión no entrarían en un ensayo clínico. Por lo tanto, eso nos tiene que plantear cambiar, ¿no? Aspectos regulatorios de cómo se están desarrollando los ensayos clínicos. Por ejemplo, también en Cataluña hemos registrado toda la actividad en relación a la presencia de tentativas de suicidio. Sabéis que, no sé si ha ocurrido lo mismo en Colombia, pero tenemos un incremento progresivo de las tentativas de suicidio en nuestro entorno. Hicimos un estudio con un registro poblacional y pudimos medir esa tendencia y vimos algo que probablemente es bastante obvio, ¿no? Después de la pandemia, un incremento significativo de prácticamente más del 50% de tentativas, ¿no? Y tentativas que afectan fundamentalmente a jóvenes y a mujeres, ¿no? El análisis de estos datos nos permite desarrollar políticas para intentar actuar a este nivel, ¿no? Otros aspectos que nos interesan, ¿no? Ya desde una vertiente más neurocientífica, es poder actuar a nivel de factores de riesgo, ¿no? Estuvimos hablando del exposoma, ¿no? Y sabemos que el trauma es un factor que incrementa el riesgo del desarrollo de múltiples patologías, tanto de salud mental como de salud somática o física. Y por una sensibilidad del servicio de obstetricia de nuestro hospital, queríamos ver las pacientes que sufrían un trauma obstétrico. Sabéis que el trauma obstétrico es muy frecuente, prácticamente el 45% de las mujeres refieren algún tipo de situación traumática en el contexto del parto. El servicio de día quiere de alguna forma poder identificar este problema y nos pide si podemos establecer algún tipo de marcador que pueda predecir que una persona que ha sufrido este trauma, que puede ser un trauma objetivo o subjetivo, puede desarrollar un trastorno relacionado con el estrés. Estamos haciendo un seguimiento, estamos identificando esas pacientes que han sufrido tanto trauma objetivo como subjetivo, las estudiamos, las seguimos, identificamos aquellas que han acabado desarrollando un trastorno relacionado con el estrés y tenemos todo tipo de marcadores que nos pueden permitir prever, después de una situación de trauma, quién de esas pacientes puede acabar desarrollando en un futuro un problema como la depresión, como los trastornos de ansiedad, como el estrés o el trastorno de estrés postraumático. Otro aspecto que nos interesa también en este sentido es evaluar otros factores de riesgo, en este caso la presencia de bullying. Nos hemos aprovechado de una cohorte de jóvenes que están siendo seguidos desde su nacimiento hasta la actualidad. Estos jóvenes ahora tienen en torno a 20 años y tenemos muchísimas medidas. De hecho, esta cohorte se desarrolló para evaluar el impacto de la polución en la salud de estos jóvenes. Nosotros hemos propuesto también ver en qué medida diferentes factores pueden también promover o incrementar el riesgo de que estas personas desarrollen a lo largo de su vida un trastorno de salud mental. Tenemos datos clínicos, tenemos datos genéticos y tenemos datos de neuroimagen. Y ahora ya hemos empezado a hacer los primeros análisis de estos. Prácticamente hemos conseguido escanear, ¿no? Hacer un escáner a la mitad de esta muestra, de esos 600 jóvenes que hemos seguido, que tenemos absolutamente evaluados durante más de 20 años, con la intención de poder identificar estos biomarcadores de riesgo en población que en este momento son población sana. Otro aspecto que para nosotros es muy importante es optimizar los tratamientos que estamos desarrollando. Por ejemplo, la introducción de tratamientos como los que ha comentado antes Joan, ¿no? Como la esketamina, como un antidepresivo de acción rápida, nos plantea la posibilidad de poder definir biomarcadores que de alguna forma predigan la respuesta a estos tratamientos. Son tratamientos más costosos, son tratamientos que probablemente pueden tener un efecto específico, no globalmente sobre la depresión, sino sobre diferentes dominios que componen la depresión, y estamos estudiando con resonancias secuenciales la evolución de estos pacientes, ¿no? Con esta intención de poder incorporar desde una perspectiva multimodal, no solamente desde la perspectiva de neuroimagen, sino también con diferentes medidas ómicas, poder establecer biomarcadores de respuesta. Tenemos, por ejemplo, algunos datos que una estudiante nos ha hecho hace poco con la mitad de una muestra, ¿no? que van en esa dirección, en lo que decía Joan, ¿no? La depresión como síndrome parece que no tiene ningún tipo de valor y, en cambio, dominios específicos, en este caso como por ejemplo la anedonia, parece sí que permite establecer una predicción de respuesta. Otro aspecto que, bueno, aquí yo creo que vosotros tenéis que decir algo, ¿no? Porque esto es una propiedad vuestra ancestral, ¿no? Que es los psicodélicos. Estamos desarrollando tratamientos psicodélicos en diferentes trastornos mentales, entre ellos depresión, y se nos ha planteado un aspecto importante. Sabemos que los psicodélicos tienen un efecto terapéutico muy robusto, muy consistente, pero también tienen riesgos, ¿no? Y la experiencia psicodélica puede condicionar también situaciones de episodios psicóticos o estrés postraumático en ese contexto. Nos hemos planteado en qué medida la experiencia psicodélica es necesaria para conseguir determinados efectos terapéuticos. Entonces hemos planteado, vamos a empezar ya un estudio en el que pretendemos comparar pacientes que reciben psilocibina más placebo y pacientes que reciben psilocibina más pimavanserina, que es un antipsicótico que se utiliza en el tratamiento de la psicosis del Parkinson y que es un antagonista inverso del 5-HT2. Y sabemos que el bloqueo de esos neurotransmisores bloquea la experiencia psicodélica. Nuestra idea es ver en qué medida la experiencia psicodélica es esencial para conseguir efectos terapéuticos, en este caso antidepresivos, en el tratamiento con psicodélicos. Es interesante. Yo creo que desde Sudamérica y Latinoamérica tenéis que levantar la mano porque los psicodélicos son de aquí, son vuestros, claramente. Otro aspecto que también estamos intentando desarrollar es la neuromodulación. 1 minuto tengo. Y la neuromodulación estamos integrando neuromodulación no invasiva, pero tenemos mucha tradición en neuromodulación invasiva, ¿no? fundamentalmente en estimulación cerebral profunda. Nosotros sobre todo hemos trabajado en depresión y en esquizofrenia. Tenemos del orden de unos 30 o 40 pacientes tratados con estos trastornos. Y, por ejemplo, este estudio que publicamos hace poquito demuestra que la respuesta no es homogénea, ¿no? Sino que podemos diferenciar 3 grupos de evolución terapéutica y uno en el que hay una mejoría espectacular, ¿no? Realmente hay una remisión clínica en pacientes con trastornos depresivos muy resistentes, altamente resistentes, pero hay pacientes que no responden o que responden de forma parcial. Otro proyecto que hemos iniciado es intentar, en la línea que comentaba Joan, poder utilizar técnicas de tracking, de neuroimagen, de registro intracerebral para poder optimizar el tratamiento, ¿no? Tanto en la selección del candidato, en la planificación quirúrgica, como en la evolución posterior de los pacientes. O sea, son proyectos muy interesantes que estamos empezando actualmente. Este es todo nuestro grupo, ¿no? Estamos en este magnífico hospital, el Hospital de San Pau, que os invito a visitar. Cuando el otro día hablábamos de la influencia del ambiente, me vino a la cabeza un poco la idea inicial del arquitecto que construyó este edificio, ¿no? Él decía que la arquitectura podía curar, que el contexto, que el entorno era terapéutico, ¿no? Y el desarrollo del hospital, las zonas verdes, los espacios, incluso los materiales que utilizó para construir el hospital, tenían ese objetivo. Tenían el objetivo de aportar, de proveer salud, porque el contexto, el ambiente, es también un determinante esencial de la salud, ¿no? Y me recordó cuando hablábamos de la importancia del contexto como un determinante esencial de salud, me recordó el hospital que os invito cuando queráis a visitarlo. Y ya está. Muchas gracias.
Muchas gracias, doctor Carter. Tenemos tiempo para una pregunta muy breve. ¿Alguien tiene una pregunta? Si no, yo puedo aprovechar, lo puedo hacer yo. Ya que mencionaba y nos ha contado mucho sobre el momento en Europa, cómo están en neuropsiquiatría, neurociencias y demás, yo quisiera saber cuáles pueden ser esos principales retos, unos o dos que ha visto, y cómo Latinoamérica y particularmente Colombia podría aportar al cierre de esos retos, esas brechas.
Mira, me encanta esta pregunta porque es algo que llevamos pensando, que yo creo que es esencial que miremos que desde Europa nos miremos, ¿entiendo? Porque yo creo que entiendo que el papel de España tiene que ser determinante, y sí que estamos empezando a establecer acuerdos comerciales, ¿por qué no empezar a fortalecer los acuerdos científicos, ¿no? Entre Europa y Latinoamérica? Yo creo que es esencial. Y viendo el vigor, la salud que tenéis en este ámbito, ¿no? Y las propuestas y la energía, yo creo que es esencial que empezamos. Yo creo que existe, ¿no? Por ejemplo, ayer te habías formado en Ramón y Cajal, Nano estuvo conmigo en Barcelona. Yo creo que esa sinergia la tenemos que aprovechar, ¿no? Nos conocemos y sabemos en qué estamos trabajando, tenemos ideas en común. Yo creo que tenemos que buscar oportunidades. Y yo creo que es una mirada absolutamente necesaria, no podemos evitar. Europa no se puede quedar atrás en este sentido, ¿no? Creo yo, ¿no? No sé qué opináis vosotros.
Completamente de acuerdo. Una más. muy breve.
Sí. Narcis, muchas gracias. Y quería preguntarte un poco sobre el estado de las oportunidades en términos también de financiación, considerando los retos actuales que hay a nivel global en financiación, no solo en el Instituto Nacional de Salud en Estados Unidos, también parece haber una invitación a ciertas restricciones, por ejemplo, en UK, el NIHR ha generado algunas preocupaciones sobre eso. Estaba pensando en tu experiencia, por ejemplo, ¿qué opciones hay de financiación que puedan permitir este tipo de colaboraciones Suramérica, Europa? No sé si en el ERC tú ves oportunidades, los modelos Wellcome Trust o modelos más específicos de organizaciones
digamos, como más privadas o otras públicas. ¿Cómo ves ese panorama?
Sí, yo creo que un problema que tenemos en Europa es que restringe mucho los consorcios intraeuropeos, ¿no? Pero sí que existe, es cierto, algunas opciones que permiten hacer estudios con países fuera de la Unión Europea. El caso de UK yo creo que parece que existe o no, se persiste en la financiación. Tenemos un horizonte europeo hasta el 2027 asegurado. Y es cierto que UK, por el Brexit y por aspectos de prioridades en la financiación, está perdiendo realmente muchas oportunidades en ese sentido. Yo recuerdo hace unos años que los grupos de UK eran los que llevaban las iniciativas en Europa y ahora están fuera de ella, ¿no? Por malas decisiones, yo creo que a nivel de Estado, ¿no? Por lo tanto, yo creo que tenemos que buscar alternativas y yo entiendo que hay muchos aspectos que nos acercan, ¿no? Y que tenemos que permitir buscar opciones, ¿no? Tú has comentado, las welcomes es una opción. Han existido propuestas específicas para colaboración con Latinoamérica y que tenemos que buscar esas oportunidades, ¿no? Y yo insisto, desde el conocimiento es mucho más fácil. Yo creo que estamos estableciendo networks que nos pueden permitir perfectamente dar una respuesta en ese sentido, ¿no? Y claro, hay que hacerlo, sí.
Muchísimas gracias, doctor.
De nuevo, muchas gracias al doctor.
For those of you who have registered to the workshop, now you can go to the term. The workshop will be in el 302 of the edificio, the 20th building. It's the one in La Séptima. So you can go now. Outside will be someone that escort you. Go ahead.
We continue here with Professor Bogan Bell. He is Professor of Clinical Psychology and Cognitive Neuropsychiatry at the University College of London and a clinical psychologist at the South London and Moseley NHS Trust. He holds a PhD in Cognitive Neuropsychiatry from Cardiff University and a doctorate in clinical psychology from King's College London. His work focuses on psychosis, delusions, and neuropsychiatric outcomes in brain injury and neurological disorders. Thank you, Dr. Bell, for being here with us. Thank you for your patience and welcome again.
Thank you, Laura, for that very kind introduction. So the first thing I'm going to do is just share my slides. 1 second. And hopefully you can see those now. So listen, firstly, thank you very much for inviting me. It's incredibly kind. I'm going to talk about why is Latin America missing from the history of psychiatry. So the first thing to say is, why is a British neuropsychologist interested in the history of Latin America and the history of neuropsychiatry in Latin America? Well, partly because I worked for several years with some fantastic neuropsychiatrists in Colombia. I learned a great deal. I left with a profound respect and understanding of some of the fantastic work that was going on here. And I returned to the UK, and it turns out very few people have much contact with understanding of the history of neuropsychiatry in Latin America. So this is really my attempt to kind of answer this question. So the first thing to talk about is which neuropsychiatry are we talking about? There's 2 ways the word neuropsychiatry is used. The first is biological psychiatry, in other words, the neurobiological basis of psychiatric disorders. We're not going to talk about that today. We're going to talk about neuropsychiatry, meaning the interface between neurology and psychiatry. In other words, people with neurological disorders and mental health problems that co-present. And if you're interested in neuropsychiatry, you can go to the scientific and the medical and the academic literature, and you can read articles book chapters, textbooks, all about the history of neuropsychiatry. And they give a very particular view of the history of neuropsychiatry. And I'm going to give you that view now. So when you read this textbook version of history, we have this understanding that there were some very early kind of scientists going back to the ancient world, thinkers from the Middle Ages who were interested in these broad themes. Then we have this pre-formation stage with lots of people who were doing things which we would now think of as central to neuropsychiatry, but they didn't think of themselves as neuropsychiatrists. Likes of Charcot, Broca, Korsakoff, Alzheimer, Parkinson's, all these names will be really recognizable, really familiar, because they defined lots of the disorders which are now central to neuropsychiatry. It was then a period of consolidation with the likes of John Hewlings-Jackson, epileptologist, who deliberately and explicitly drew on both psychiatry and neurology to better understand epilepsy. And then there was the birth of modern neuropsychiatry, the first use of neuropsychiatry in 1918, the first textbook which really defined the field, The Foundations of Neuropsychiatry by Stanley Cobb, published in 1944. And there was a slow development of the field, and then an explosion in the 70s. Publication of Organic Psychiatry by psychiatrist Alwyn Lishman in the Maudsley Hospital, the founding of the British Neuropsychiatry Association in 1987, the founding of the American Neuropsychiatric Association in 1988, and then the International Neuropsychiatric Association in 1998. And this, according to those articles, is the history of neuropsychiatry. But what this completely ignores is everything that was going on in Latin America. Because in Latin America, actually for decades before, lots of fantastic work was happening in neuropsychiatry. In 1937, Latin America had the first international conference in neuropsychiatry, the Jornada Neuropsiquiátrica Panamericana. The first neuropsychiatric journal, the Revista de Neuropsiquiatría, was founded in 1937, in the same year. The first neuropsychiatric association, the Sociedad de Neuropsiquiatría y Medicina Legal, was founded in 1938 in Peru, and the first Portuguese language journal was founded in 1943, the Arquivos de Neuropsiquiatría. So we can see here that there was a huge amount of work going on before this history that you would pick up from the kind of textbook history that's currently published in the academic literature. In fact, these journals I mentioned are still going today. You're probably familiar with them. You can publish them, you can read them today, and they've been going now for decades and decades and decades. But it's important to mention that the reason that 1937 was such an important year, you'll remember it was this first international conference and the founding of the first neuropsychiatric journal, was not the very first light of neuropsychiatry in Latin America. It's because there was already a lot of work happening. In other words, the founding of the first journal and this first international conference started precisely because there was so much work going on. In fact, this is the first neurology, psychiatry, and forensic medicine conference that happened in Latin America, and it happened in 1928 in Buenos Aires. So there was already, 9 years before, there was already neurologists, psychiatrists coming together to discuss their common interests. This international conference was originally called the Jornadas Neuropsiquiátricas del Pacífico, the Pacific Neuropsychiatric Conference, and it happened in Chile in 1937. It was eventually renamed to the Jornadas Neuropsiquiátricas Panamericanas, and this is the report that appeared after the conference. You'll notice a few interesting features. The first is it uses the old name from the conference, which makes me think that maybe it was actually written before the conference happened, but appeared as if it was reporting on the conference. If you don't read Spanish, it's quite an amazing report, actually. So it says the Pacific Neuropsychiatric Conference met in Santiago de Chile in 1937, and it's constituted, without doubt, one of the most important verified medical happenings in Chile. It's the first congress, the first conference in this specialty that happened in the country, and for the extraordinary happening with participants and numerous and transcendental work presented. It was one of the most brilliant collection of neurology, psychiatry, and forensic medicine in our continent. I thought this must have been written by a friend of someone of the conference, but it turns out Oscar Fontecilla actually was a chair of the conference organizing committee, so he kind of wrote his own review in a way. Hernando, I hope you have someone lined up to write a similarly glowing review of this conference here. You know, joking aside, this is actually a little bit of a kind of a grandiose account of the conference, but I have to say, actually, the talks were fantastic. This is just a selection of the talks I pulled out. Value of the signs of localization in the diagnosis of cerebral tumors, relationships between mental automatism and psychoanalysis, psychopathology and the clinical delimitation of early dementia, action potentials in the nervous system, in neurosurgery, and dementia and schizophrenic psychosis. So a really fantastic range of talks there. I mean, I would love to go and you know, hear some of these talks. It had a huge kind of scientific program, but it also dealt a lot with policy. It dealt a lot with social policy and discussed the role of neuropsychiatry. And actually the conference finished with some declarations. And these were: the conference considers these urgent needs and recommends the construction of modern psychiatric hospitals, the creation of psychiatric services in general hospitals, the creation of chairs, professorships of psychiatry, neurology, and legal medicine with the premises, personnel, and material appropriate to teaching needs, and the creation of federated mental hygiene associations in all nations of our continent. If you're not familiar with mental hygiene, it was a movement at the time that took a public health approach to mental health, so addressing the social conditions that may cause mental health problems rather than just treating mental illness. That was a reformist movement. It wanted to make psychiatric care much better, much less coercive, much more humane. It also had a slightly less comfortable aspect, which it was, you know, lent quite a bit on eugenics, and you know, had this kind of idea that certain sorts of people had this kind of degenerative aspect to them, and actually through using the terminology of the time, good breeding, that could be eliminated from the population. However, if we just take the public health aspect of mental hygiene, actually, this is a really modern approach to social policy, right? Good psychiatric hospitals, psychiatric services in general hospitals, well-structured, well-resourced training, and a public health approach to mental health. People attended from Argentina, Bolivia, Brazil, Chile, Colombia, Ecuador, Nicaragua, Peru, Uruguay, and the Dominican Republic, and they published a 1,088-page book of the conference proceedings. They then had a meeting 2 years later in Lima, Peru, the second International Neuropsychiatric Conference, attendees from a far wider range of countries, including the United States, and they published a 370-page book of the conference proceedings. So it's worth just taking a moment here for context and comparing what was happening in Latin America with the supposedly kind of, you know, mainstream history we get from the currently published work. So 7 years before the supposedly landmark field-defining publication of Cobb's 1944 Foundations of Neuropsychiatry, Latin America had founded 2 neuropsychiatry journals that are still going today, and had 2 international neuropsychiatry conferences. And when the British Neuropsychiatry Association was founded in 1987, we're very proud of our history. We have the 40-year anniversary in 2 years' time, so we would love more Latin Americans to come along. Please come to London and celebrate with us in our conference. But when the British Neuropsychiatry Association was founded in 1987, the Revista de Neuropsiquiatría was celebrating its 50th anniversary. I mean, really impressive, actually. However, Latin America can trace important work in neuropsychiatry before the launch of neuropsychiatry in the region. So if we think of 1937 as a really important moment for the launch of neuropsychiatry, actually this is because lots of important work was going on previously. I'm just going to give some illustrative examples here. I'm not pretending this is a complete history, but I'm just picking out some fantastic work and some really influential people who were working in Latin American neuropsychiatry in the decades before 1937, just to give you a flavor of what was happening at the time. So this is Augusto Arrego Luco. He was a Chilean psychiatrist and neurologist. Actually, if you read psychiatry journals, they say he was a psychiatrist. If you read neurology journals, they say he was a neurologist. But he's frequently called the Charcot of the Americas, after Jean-Martin Charcot, the foundational French neurologist. He founded the Chilean Society of Neurology, Psychiatry, and Neurosurgery in 1932. He researched anatomical clinical methods, in other words, looking at pathology, psychopathology, looking at pathophysiology, looking at lesions, looking at how these things are connected to understand mechanisms. He researched hysterical and organic paralysis, hallucinations, and neuroses. So really kind of key neuropsychiatric topics. This is Juliano Moreira. He was a brilliant Brazilian psychiatrist, a black Brazilian psychiatrist. He founded the journal, the Arquivos Brasileiros de Psiquiatria, Neurologia e Ciências Afins in 1905. This goes way back. He was director of the Brazilian Society of Neurology, Psychiatry, and Forensic Medicine, and he made important contributions to understanding neurosyphilis, the social causes of neuropsychiatric illness, and he's frequently called the father of scientific psychiatry in Brazil. This is because he was very opposed to lots of the racist theories that were part of eugenics at the time, that said that mental illness was caused by racial mixing because some races were inferior, and that racial mixing was causing degeneration to spread and affect the human race. He thought this was deeply racist, which it was, and he opposed these theories. But he opposed them not only by arguing against them theoretically, but by going out and doing some really important empirical and epidemiological work to demonstrate that some of the risk factors for mental ill health were not down to people's race, but down to the social conditions in which they lived. So he was a real pioneer in empirical psychiatry, as well as being a great humanist. This is Carlos Monge Medrano. He wasn't a psychologist, he wasn't a psychiatrist, he wasn't a neurologist, he was a physician, but he identified chronic mountain sickness. He was researching altitude sickness, and he was studying kind of populations in Peru who lived at very high altitudes, over 3,500 meters, and did a lot of work not only on the physical consequences of chronic mountain sickness, but also the neuropsychiatric consequences. He was a real pioneer in high altitude medicine, and lots of that work became really important when aeronautics, air flight, and even space flight became really key in later years. This is a really fascinating person. This is Manuel González Echeverría. He was a Cuban psychiatrist and neurologist. He worked in London and he worked in New York. He actually studied his medical degree in Paris. He moved to London. He worked in both the Bethlehem Hospital, which is like one of the key hospitals for the development of psychiatry. He then also worked in the National Hospital, which is the kind of key kind of hospitals for neurology. And at that time, it would have been quite rare to work both in psychiatry and in neurology. They often kind of considered each other with a bit of suspicion. But he worked in both of those areas with some of the leading neurologists and psychiatrists at the time. He then moved to the United States, and he wrote the first ever book on epilepsy to come out of the United States. It was called On Epilepsy, Anatomical, Pathological, and Clinical Notes. And he published extensively on the neuropsychiatric complications of epilepsy, on, using the language of the time, epileptic insanity, epileptic violence, alcoholic epilepsy. By the way, this is just a bit of an example of sometimes how Latin Americans are not kind of recognized for their work. This is from a fantastic book, actually. This is Simon Chauvin's book, The Idea of Epilepsy. It's a 600-page history of epilepsy from 1860 to 2020. And I was reading this book, and it says, in the United States, the main contribution in epilepsy was the book by Manuel Echeverría, a New York alienist who had trained at the National Hospital in London, and whose book shows the strong influence of his colleagues, Gowers and Jackson. And I was reading this and thinking, Manuel Echeverría, that guy doesn't sound like a gringo. And I looked him up, and of course he was Cuban. He's mentioned a lot in Simon Chauvin's book on the history of epilepsy because he made so many really important contributions to our understanding of epilepsy. To Chauvin's credit, there is a small footnote where he notes that Echeverria was born in Cuba, but actually you have to look quite hard, and despite the fact he turns up quite a bit, is mostly, if you read the book, you would think he's from New York. Actually, Echeverria eventually returned to Cuba. He finished his career in Cuba, but made a massive contribution to our understanding of epilepsy at that time. I looked quite hard for women who made a contribution to neuropsychiatry at that time. I couldn't find many, and I'm sure this was because there were many barriers for women entering medicine, and a great deal of kind of marginalization of women who wanted to go into medicine. I will give a little kind of footnote to that in a second, but this is Iracy Doyle Ferreira, Brazilian child psychiatrist. She founded the Instituto de Medicina Psicológica. Now she's better known as a psychoanalyst, but actually she did important work on neurodevelopmental disorders and neurosyphilis. Now, I have to say, with regard to what I mentioned about not many women entering medicine at that time and there being lots of barriers, and so there weren't many women contributing at the time, I would have said the same about women in psychology. And then I read Rubén Ardila's brilliant book, La Historia de Psicología en Colombia, and it turns out that there were quite a few important women contributing to psychology in the history in Colombia, even in the 1800s, but they were kind of written out of history or haven't been recognized. So I will just say that, the extent to which women haven't been recognized, I'm sure is, partly down to the fact that there were far fewer women working in neuropsychiatry at the time. It may also be the fact that no one's researched it in sufficient depth to understand some of the contributions that were made. And of course, there can be many more recent historical figures. I've been talking about the late 1800s, the early 1900s, but we could mention many others. This is just a list of people that came from the kind of top of my head, a little bit biased towards people in Colombia, but we could talk about Francisco Lopera, the neurologist, done lots of fantastic work in dementia in Colombia. Jorge Holguín Acosta, the father of pediatric neurology in Colombia. Matilde Rodriguez Cabo, the first female psychiatrist in Mexico, did a lot of work on neurodevelopmental disorders. Germán Berríos, psychiatrist, Peruvian, spent most of his career in Cambridge here in the UK. Alfredo Ardila, Colombian neuropsychologist, one of the first neuropsychologists in the world to start thinking about how to apply neuropsychology to understand psychiatric disorders. Ramón de la Fuente Muñez, foundational psychiatrist in Mexico who really did a lot of work integrating physical health and mental health. Edmundo Rica Tejada, psychiatrist, actually Colombian psychiatrist, actually studied with Charcot in France and then came back to Colombia and founded a lot of kind of forensic psychiatry, did lots of work. I'm sure there are many, many other kind of historical figures who you could identify as having made an important contribution to neuropsychiatry in Latin America. So given this incredibly rich history, we need to ask ourselves, why is Latin America missing from the history of neuropsychiatry? Was it ignorance? Was it racism? Was it this fantastic Portuguese, Brazilian word, clubismo, that kind of translates to cliquishness, clannishness in English? Well, possibly, although there's good evidence that there were strong international links. So this is from a book published by the Peruvian Society of Neuropsychiatry on the 25th anniversary of their foundation. And this is the list of honorary foreign members of the Peruvian Society of Neuropsychiatry. And I'm just going to highlight the people from outside Latin America here. So here's Herbert Oliver Kroner. He was the first professor of neurosurgery at the Karolinska Institute. Folke Henschen was the professor of pathological anatomy at the Karolinska. Hans Hoff was the head of psychiatry and neurology at the University of Vienna. Nolan D.C. Lewis was a director of the New York State Psychiatric Institute. Jean Delay discovered chlorpromazine as an antipsychotic. E. Arnold Carmichael was the director of Britain's MRC Neurological Research Unit. Aubrey Lewis was the head of the Institute of Psychiatry in the Maudsley Hospital in London. William Scoville, that should be a V, was a neurosurgeon. He established the Department of Neurosurgery in Connecticut. Norman Dott was the first professor of neuropsychiatry at neurosurgery at Edinburgh University. Paul Bucy was a neurosurgeon of Kluver-Bucy syndrome fame. John Rees was the president of the World Federation for Mental Health. Earl Walker was a neurosurgeon of Dandy-Walker syndrome fame. And this is Viktor Frankl. Probably needs no introduction, but if you're not familiar with him, Holocaust survivor, psychiatrist, neurologist, developed logotherapy, wrote one of really amazing book, Man's Search for Meaning. I think it's called El Hombre en Búsqueda de Sentido in Espanol. A little kind of historical note here. Viktor Frankl, survivor of the Holocaust, Volker Henschen, Nazi. I mean, he's from Sweden, but was actually a member of the Nazi Party. So probably a little bit of a cultural misunderstanding the other way around here to invite them both to be honorary foreign members. Regardless, what this shows us is that Latin American neuropsychiatry in the 60s had really strong international links. There were lots of people, the great, the good, the leading lights of psychiatry, neurology, and neurosurgery who were part of the network of Latin American neuropsychiatry in the 1960s. So I don't think it is the case that the reason that Latin America is missing from the history of neuropsychiatry is because people thought that it wasn't very good or weren't interested or didn't want to be associated with it. Actually, some of the leading people in the field wanted to be associated with it. Is one of the reasons that Latin America is missing from the history of psychiatry down to loss of influence? The Chilean historian Claudia Raya Ibacache argued that the jornadas neuropsiquiátricas panamericanas were an attempt to position psychiatry as central to the fate and progress of Latin American nations, hence all their focus on social policy. But this project ultimately failed due to slow scientific development in the region and economic dependency on North America. In other words, actually, the governments were really, really focused on trying to align their economies with North America to gain those economic benefits and didn't really want to engage with other ideas that may help the fate and progress of Latin American nations, at least as far as neuropsychiatrists saw it. Was one of the reasons that Latin America is missing from the history of neuropsychiatry? Is it because some of the people had quite dubious and uncomfortable ideas? So several of the figures I mentioned also had some quite uncomfortable views. Several were eugenicists, including, by the way, the Black Brazilian psychiatrist Juliana Moreira. He was an anti-racist. He didn't believe in any of the racist theories of eugenics, but did believe in the sterilization of alcoholics. Araceli Doyle argued that homosexuality was a mental illness, although did propose a quite compassionate approach to homosexuality. Mental hygiene in Latin America still had this clear focus on degeneration, the idea that certain members of society were, if they bred and their influence became, kind of important in the gene pool, then it would cause more mental illness. So was it the case that, Anglo psychiatry wanted to distance itself from Latin American neuropsychiatry because of these dubious ideas? I don't think so, because actually there were lots of people in Anglo neuropsychiatry who also had some pretty dubious ideas. Eugenics was actually a very common belief, even in kind of for left liberals at the time. Aubrey Lewis, the head of the kind of Maudsley Hospital Institute of Psychiatry, was a member of eugenics associations. And that hasn't stopped them being identified as really important in the history of neuropsychiatry. Was the reason Latin America doesn't feature in the history of neuropsychiatry because it largely focused on regional concerns? So it is true that the studies on the neuropsychiatry of tropical disease and altitude sickness have been landmarks in medical progress, but are not considered key to Anglo neuropsychiatry, partly because we don't really have mountains high enough, we don't really have tropical disease. That may change with climate change. But it is the case that some of these things are really important in Latin American neuropsychiatry. So, for example, in a recent article in the Archivos de Neuropsiquiatría, De Rosa et al. Looked at all of the articles published in that same journal from 1943 to 1962, and neuroinfections were the single most common subject for articles. You know, the neuropsychiatry of neuroinfections is really important in Latin America in a way that it traditionally hasn't been in Anglo neuropsychiatry. So is this the reason that it hasn't featured? Because Latin American neuropsychiatry was focused on things that are just considered kind of local or regional concerns? I don't think so, because actually Latin American neuropsychiatry has had a very broad focus, as we can see from some of those talks from the first jornadas de neuropsiquiatría. Actually, there's lots of common interest between Anglo and Latin American neuropsychiatry historically. Is it down to language barriers? Well, possibly this didn't help. I mean, it is the case that almost all people working in neuropsychiatry in Latin America will understand English. I was asked to present in English to a Colombian and Latin American audience. Very rarely will Latin Americans be asked to present in Spanish to Anglo audiences. However, this may be a bit of a barrier, but French and German clinicians are part of this kind of mainstream history of Anglo neuropsychiatry. Despite there being similar language barriers, that hasn't really stopped them being recognized. So language barriers may cause a bit of problems, but I don't think there's a reason that actually Latin America is not part of the published history of neuropsychiatry. I suspect this is probably the major factor, but I would love to hear what you think. And these, you might describe them as geopolitical barriers. So while the boom in neuropsychiatry was happening in Latin America in the 30s and 40s, 50s and 60s, the rise of Anglo neuropsychiatry happened in the 70s and 80s. So you remember that this textbook was published in 1944, Stanley Cobb's Foundations of Neuropsychiatry. There was a slow growth, and then there was a boom in the 70s where the first professors of neuropsychiatry occurred. People started considering themselves neuropsychiatrists, and it was a very specific development of the field in Anglo countries. In 1977, all but 3 of the 20 countries in Latin America were under dictatorships. There were also armed conflicts and all political violence in Guatemala, El Salvador, Nicaragua, Colombia, Peru, and Argentina. You know, this led, I suspect, to you know, real problems with the networks of communication and collaboration between Anglo and Latin American neuropsychiatry. I suspect these were partly down to political reasons, people not being keen to collaborate with you know, countries which are under dictatorships, partly down to the impacts of violence and armed conflicts on some kind of external collaborations with other countries in Latin America itself. Certainly when I came to Colombia in 2008, it was very, very, very rare for kind of Anglo foreigners to come to Latin America at that time. Very, very few kind of English-speaking Anglo academics had much contact and were visiting Latin America. So when the rise of Anglo neuropsychiatry occurred in the 70s and 80s, I think many were simply unaware of Latin American history because they had little access to it through shared networks. There weren't many people with that knowledge and understanding of Latin American neuropsychiatry who were there to go, hang on a minute, I've read your history article and it misses out some really important developments that happened outside your region. Obviously, Anglo neuropsychiatry has written what it thinks is the history of the field, supposedly the history of the field, without the benefit of knowing the wider history and the history of neuropsychiatry in Latin America. So, as well as asking this question, why is Latin America missing from the history of neuropsychiatry? And I hope I've suggested a few ideas why this might be. We also need to ask, how can we ensure Latin America has the place it deserves in the history of neuropsychiatry? Certainly as someone who works in neuropsychiatry in the UK, I hope to you know, really kind of promote the role of Latin America in terms of the history of neuropsychiatry. I've learned a massive amount from working in neuropsychiatry in Latin America. As the current president of the British Neuropsychiatry Association, I really hope to be able to promote that and promote some of the kind of global progress in neuropsychiatry. But I think also conferences like this are going to be absolutely key. the conferences that kind of connect outside Latin America and also bring people in to Latin American neuropsychiatry. Certainly Latin American neuropsychiatry is really kind of booming at the moment. Lots of fantastic research and clinical practice going on. So I profoundly hope this conference is going to be one of the ways that we can ensure Latin America has the place it deserves in the history of neuropsychiatry. Thank you very much.
Thank you, Dr. Bell, for that amazing presentation.
Thank you, Dr. Bell. It was a really engaging and nice presentation to watch. I wanted to ask if anyone has questions in the public. Well, I have a question. I was thinking, how do you think that language is also a political problem to enter into history? As you said in the presentation, lots of Colombian and Latin American researchers speak English, but it doesn't happen in the other way around. You are one exception, but what I mean is like we are not being read in other languages, and also the magazines like the 10th, even in Colombia, are trying to get published in English. So do you think that it can, I don't know, like more than ensure visibility, also complicate the visibility of regions where we don't speak English as fluently, or we don't write in English like so fluently?
Yeah, it's absolutely the case. English, for better or worse, has become the language of science, which means that English is actually, completely blind to lots of the fantastic progress that's going on in, lots of other parts of the world. And it's definitely the case. It's also, a bit of a barrier that, you need to be able to speak English to be a scientist, be a clinician. At least, I've met certainly plenty of researchers in Colombia and other countries who have what I might call read-only English. And actually, it's still quite a barrier to kind of, publish in English and write in English. I have the same in Spanish, right? I can kind of, converse and read in Spanish, but actually, if I had to write unaided in Spanish, I would, to the level needed for academic publication, it would be a real problem. I have to say, I'm hopeful that the birth of AI, is really going to make a difference here. AI is brilliant at translations, and you can write in English, and I can go translate this into Colombian Spanish, translate this into Peninsular Spanish, and it does a really, really good job. So I'm really hoping that artificial intelligence will help break some of that barriers. It also means, by the way, that I can send articles written in Spanish or Portuguese to my non-Spanish and Portuguese doctoral students and go, read that, and they can go away and translate it and understand it. So yes, Laura, I completely agree. It definitely is a barrier. I'm hoping it's going to become far less of a barrier. And one of the things I profoundly hope is that particularly English language clinicians and researchers will get a far better appreciation of all of the fantastic work that's published in Spanish, and they might never get to see otherwise.
Thank you very much, Doctor. It's been a huge pleasure to have you here and to see you again. So I hope you have a pleasant evening, and thank you very much for your presentation.
Thank you so much for inviting me, and all the best from London. Thank you all.
Before you go, we have still with us some international speakers. Voy a hablar en español entonces. Según el programa que tenemos todos, hasta aquí llegaría y será la última sesión. Sin embargo, tenemos una pequeña sorpresa. Como parte del workshop que están haciendo ahorita, va a participar el Dr. Bruce Miller. Él es el director del UCSF Memory and Aging Center. Y logramos hablar para que podamos ver la charla inicial de él. Vamos a verla de forma virtual, entonces no vamos a poder como interactuar directamente con ellos, pero vamos a poder conectarnos a verla. Solo dame un segundo mientras nos uno.
Most of them are early career mentors. There are a couple senior mentors from the university here, Javeriana. We're just starting the workshop, so we've just introduced ourselves and set expectations a little bit, and now we welcome you to talk a little bit about values and leadership.
Fantastic. What an honor. I so wish I was with you. And,
Nos unimos a tiempo.
you know, I think Victor introduced me as his mentor in many ways. He's my mentor. These relationships are extraordinary. And I think often as mentors, we get far more back than we can ever possibly give. I'm going to talk about value-based leadership. This is something that I think is somewhat unique to GBHI. Many training programs spend a lot of time teaching people facts. And of course, facts can be read in books. They're important, but I think the impact of people wherever they are is really strongly linked to who they are as a person. Are they empathic? Are they fair? Are they respectful? And, you know, these are the things that I think don't necessarily come naturally to all of us. I would say I was not a natural in this space and never took any leadership training until GBHI came along. I had a father who was an academic psychiatrist who was very gifted in these skills and was pretty tough on me when he felt I strayed away from the right path. And I think that you know, that was the kind of mentoring I could take. Some people, you know, might be more sensitive and don't like criticism, but my gosh, if we can't take criticism, if we can't listen to how other people perceive us, we are not going to live to our maximum potential. So I'm going to talk at first about empathy. Can you see my slides, everyone?
Yes. Yes.
Okay, great. I'm going to talk about emotions and empathy. And as Victor has said, we've evolved a set of values called a force. And this is what we want to see in a leader: authenticity, fairness, openness, respect, courage, and empathy. And I'm going to, in the first part of my talk, emphasize empathy. I think empathy tied to doing. Empathy is a feeling, but if we don't do anything with that feeling, you know, it floats in the clouds with no significance. So empathy is very strongly tied to altruism or doing. And, you know, this is something that I increasingly learn over the years, how important that moving that sets of emotion into action, you know, is how ultimately we will be effective leaders. So I'm going to start off with the more difficult part of the talk, which is a little bit about the physiology of emotions. I think a lot of what we do as leaders is take control of our emotions. I have the best grandson in the world. He's 12.
We are still in your title slide. Were you
Yeah, I haven't moved yet. Yeah, I'm just.
We were a little worried. Okay.
I promise I will move. I will move. I have this incredible grandson that, you know, people who know me know how important he is. He's going through puberty, and this is a time when our emotions start to ride high, and it's the beginning of a time when if we are going to be effective leaders, we take control of our emotions. And sometimes as a leader, I've failed in this space. I've gotten angry. I've been disrespectful. I've shut down. I've lacked openness. So these are things that I think a lot about, the mistakes that we make. But a lot of it is really the control of emotions. So this is from my friend Bob Levinson, who I've collaborated with almost since I arrived at UCSF. And there was a lot of basic research done on emotions by Bob Levinson and Paul Ekman at UCSF. And they realized how much the face tells us. And these are Paul Ekman faces that capture, and these are mostly translatable across culture. This first face, I think we all realize is angry. If we saw that guy in a bar, we might want to move down to a different table, because we know with anger, when it is tied to action, is really a threat. Here's another negative emotion, disgust. And we can see by the wrinkling of the nose, the pursing of the lips, that this person finds something physiologically unpleasant, whether it's internal, whether they have an ulcer, or whether they're seeing something in their environment that, again, is potentially a threat, contamination. This is the raison d'etre of disgust. Here's another face with extraordinary fear. And, I think when we see this in our mentees or in our patients, we are not going to be successful unless we perceive it and figure out a way of making that fear diminish. So emotions are short-lived. They have a psychological component. We alter our attention response to the different emotions, and they also activate in all of us memory networks. There's a physiology that Kate and Virginia Sturm and Howie Rosen have written a lot about, that talks about how we activate the facial expression with emotions, our muscular tone, our voice, and our autonomic nervous system. And these are signals that some of us are good at picking up, others are not. I think one of the general themes of social psychology is being in a vagal state where we are not angry, agitated, disgusted, is the best way to interact in social situations. Okay, so I touched on this, but these are all emotions that are there to help us understand the world and make appropriate responses. So lots of the negative emotions are associated with threat, loss, contamination, a sense that we are being treated unfairly. The positive emotions, nurturant love, amusement, embarrassment, pride, these are things that, are very positive in our lives as people and as mentors. And tapping into those positive emotions throughout the day as we move from one Zoom meeting to another, is really key to successful mentoring. Okay, so I'm going to spend a little bit of time on empathy. I think, this is really the key emotion. If we're empathic, we tend to be fair. If we're empathic, we figure out authentic ways of interacting with others. we're respectful. So I'm going to talk a little bit about this emotion, and it really interesting. I through GBHI, I met with a leader of a major university, and I was talking with him, and he said, "Well, I don't think you can teach values." And I listened. I think it said something about this leader, but I was astounded. But I think this is the go-to. This is what people generally believe. There are things like playing golf or tennis that when we practice it, we get better. If we learn a musical instrument, it again is repetitive practicing, working on our flaws, steadily improving this. But for some reason, people in many societies believe that things like empathy, somehow are outside of the normal functions of the brain. They aren't. So I think empathy is something that, we get a pocket of this in our brains when we're born. But a lot, we have the opportunity to develop it. How do we develop it? We develop as a mentor through repetitive practice. The ability to understand and share the feelings of others. Think about those faces. First of all, we have to be tuned in to understanding when someone is feeling badly. We recently had a Zoom meeting where in the course of mentoring, I was critical of someone. What I was saying was absolutely right and important. And I think the person would have done badly with the project if they hadn't listened. Victor pointed out that I wasn't in the room and not seeing, the feelings of people as they were listening to it, locked me out to some extent of being really a cautious, careful mentor. So I think, this is so critical and it's a problem with Zoom. Is sometimes the fine-tuned ways that we can detect how someone is feeling is blocked. Without it, I think our mentoring is doomed. So this is from Virginia, and she's taught me everything I know just about around empathy. And it's a multi-layered system that we have in the brain. It begins with perception. I've learned with frontotemporal dementia, and Kate Rankin has taught me this, that if your right anterior temporal lobe is not working well, your ability to perceive the emotions in a photograph like this one is blocked. That's the beginning of empathy, isn't it? It's seeing what someone else is feeling. If you can't tell that that woman is sad and worried from her face, you will have trouble, helping her in her world. In frontotemporal dementia, this is a major feature. And isn't this interesting that a small injury in the right anterior temporal lobe will devastate this whole empathy system. So if you have degeneration of the right anterior temporal lobe as the first manifestation of your dementia, about half the time you lose empathy for people. So then there are two different streams of empathy. And, one is more primitive. It's very, tied to the autonomic nervous system. It's not so different from a reptile or a bird. And this is called emotional contagion. And we've all seen it when a flock of birds, is frightened. One of them will fly and all of the other birds will follow. And this is a very primitive signaling system that allows us to take signals from members of our species and react in a very quick, appropriate way. The other side of empathy is something that is much more closely tied to values, and that's cognitive empathy. But let me make a comment about the Trump administration. I know many of you are great fans. I'm not. Kidding. I'm kidding. I'm not a fan. And I was listening to the news today, and there was someone on the news talking with a commentator. And I listened to the person, and I immediately said, oh, I didn't see the person. I didn't really even hear very much about what they were saying. But there was somebody who was really fighting with anger and, constant interruptions. The monitor who was just trying to understand something. And, this is the style of that administration. Lots of emotional contagion, quick anger, all of the autonomic response to that, the fight flight system is activated, that emotional autonomic piece is activated. The other part of this is, I think, that they have a different view that is templated in this space of cognitive empathy. And that, that's the idea that people around us are there to be helped. They're our friends. As leaders, we need to make people feel good. And I think a lot of times members of that administration have difficulty with cognitive empathy, understanding the situation that other people are in. In fact, Elon Musk, one of the leaders in this, has called empathy a blight of the 21st century. He thinks that it does harm by being empathic to other people. So I think when you have leadership or mentoring or whatever you want to call it, where the cognitive piece of this, the value piece of this isn't there, it's pretty easy to flow into this state of emotional contagion, with anger often being the response. And then finally, all of this is designed and probably evolved evolutionarily to protect and help other people in our species. It's the affiliation, compassion, the doing. If we see this poor woman on the street in distress with these two children, many of us might think, how can I help? Could I give her some money to help her buy breakfast for her children, buy milk? And this was, I think, the most beautiful system in the human brain. And it is in constant activity when we mentor. Okay, so the emotional empathy, we try to get control of this. It's harder in puberty. Honestly, it was harder as a young man for me to dampen down this emotion that I would experience. In the case of empathy, it's good, but I think in the case of anger, it's bad. So all of these emotions have different parts of the brain that are activated. The theme is fight and flight with the sympathetic system. We almost never, when we are in the process of mentoring, want to be in the flight and fight sympathetic mode because I think it activates more negative cognitive thoughts. We want to be in the calm state where the vagus nerve is taking dominance. Points out that this is the beginnings of empathy. We see in a nursery, one baby cries, all the babies cry. So this is the beginning of emotion. But as mentors, we become really fine-tuned in the regulation of emotion. One of the reasons I think that sometimes we get better at emotional regulation as we get older is that these are systems in the brain that are relatively spared by the aging process, maybe even enhanced. So no one would say at 75, I can remember as well as I did when I was 20. Just ain't true. And that's because memory systems decline as we get older. even if we don't have Alzheimer's disease. On the other hand, these emotion systems in the insula, anterior temporal lobe, anterior cingulate cortex, these all stay relatively intact unless we get strokes or unless we get a neurodegenerative disease like frontotemporal dementia. So I think that's a lot, one of the reasons that people like me, many of you, were very tied to an elder, a grandfather, a grandmother. I had major mentoring from elders in my life. It's a natural connection. You know, elders have seen it all. They can put things in perspective. And they're very good at regulating emotions and not, you know, making other people feel unnecessarily uncomfortable. A really interesting aspect of aging. Okay, so again, and I think you know this well, we have a sympathetic autonomic nervous system. It's designed to detect threat, and our heart rate increases. We start to breathe more rapidly. Our conductance in the skin is high. This is noradrenaline, and it's good for, you know, if you're about to go into a football game or you're about to play tennis. It's not so good when you're about to sit down with a mentee to think about their future. Parasympathetic autonomic nervous system is a system that is really designed to help us with social communication. Lower autonomic arousal, our heart rate slows, our respiration slows. We have more heart rate variability because the vagus nerve is taking dominance in the conduction of the heart. And this is the state that we get into when we are ready to mentor. And you with practice can learn how to upregulate these different systems. The person who has, you know, really shown this, a brilliant man, the Dalai Lama, and he has studied the autonomic nervous system. He understands that the parasympathetic autonomic nervous system is the state that he must be in as a leader. And it's associated with more heart rate variability. If you want to live long, you want higher heart rate variability. It's a profound influence on the duration of our life. If we are constantly in sympathetic arousal, not only will we make life more difficult for people around us, we will live shorter. Okay, so it's associated with social engagement, empathy, emotion regulation, positive emotion, pro-social behavior, optimism, and agreeableness. And I love this quote from the Dalai Lama: be kind whenever possible, and then it is always possible. I think this message is such a beautiful one. I think the Pope, who we recently lost, embodied values like this. And I think it was why he had such a profound influence as a leader. Okay, so we're not the only species that does this, but I think we're much better at planning and regulating pro-social behaviors. Elephants, great apes, they all have emotional contagion and the ability to activate pro-social behavior, but we're probably the best at it, and also probably the worst at it. So I think we're incredibly good at down-regulating all of these positive emotions and doing great harm to other people. It's the paradox of human living. Kate Rankin, a profoundly important paper in understanding frontotemporal dementia. And she showed, not just frontotemporal dementia, all dementias, that the right anterior temporal lobe, an area that we should work on and improve and increase connectivity, and the medial frontal regions on the right side. The right side is our social brain. are critically important for real life empathic behavior. And when you have patients who, because of a degenerative disease, because of traumatic brain injury, for some people are just born with a very, very small empathy circuit. This has profound implications for relationships with other people. So empathic people who lose this system lose empathy. People with disorders like autism spectrum disorder sometimes have really bad deficits in empathy. And this is part of the human condition I don't quite understand, but sometimes people are really drawn to leaders who lack empathy. You can think of examples in our current world where the actual unempathic, cruel response is admired. But again, this is not only the circuitry of empathy, it's the circuitry of mentoring. This is a patient of mine that began drawing when he developed degeneration of the right anterior temporal lobe. And he was very cruel to his dog. When you see this picture, you can see he sees the dog as being cruel to him. So his perceptions were profoundly altered. He could not have a relationship with anyone, but these pictures here show him imagining relationships. And these are kind of haunting because when you look at the faces, they don't really show a response of the face that suggests an emotional relationship. These people are distant. And again, this patient had degeneration of the right anterior temporal lobe and could not really express empathy or understand it in the way that all of us can. So we've thought a lot. This is Virginia Sturm's work about pro-social behavior. And in the laboratory, they have a paradigm where the examiner drops their keys and the patient can show concern and try to help or complain or ignore it. The punchline is healthy controls and people with Alzheimer's disease showed pro-social behavior. They tried to help. Patients with degeneration in the frontal and anterior temporal lobes did not. So just emphasizing how hardwired these circuits of social brain really are. So I think there are leaders that I admire, and Desmond Tutu is one of them. And what he talks about is values. A person with Ubuntu, African word, is open and available to others. Affirming of others, affirming is so important. I think looking, listening, nodding, this is the beginnings of relationships. Does not feel threatened that others are able and good or in some way taking something away from them, is based on a self-assurance that comes from knowing that he or she belongs in a greater whole. And that's what we are. We are all interdependent. If the planet's climate goes badly, we will all do badly. And so this greater whole is one of the reasons that we were able to evolve from groups of 2 or 3 people into massive civilizations, because at least some people realize that we are part of a greater whole. And when the greater whole is diminished, when others are humiliated or diminished, and when others are tortured or oppressed. So simple. It's so simple. And anyone who leads without this concept of Ubuntu is going to alienate and harm, large pockets of the population. So important. When you go to the ballot box, I think this should be a checkoff required for everyone who votes. Does that leader have Ubuntu? Think about your leaders. I know I think about ours. One of my favorite presidents was Barack Obama. And he got this. He got this. He wasn't trained in physiology. But Barack said the biggest deficit we have in our society and the world right now is an empathy deficit. So true. Think of people being sent to prisons in El Salvador. What is going on in the brains of people who do this? We are in great need of people being able to stand in someone else's shoes and see the world through their eyes. Bob Dylan has a song, if for just one moment I could be you and stand inside your shoes, you would see what a drag it is to be you. And, you know, it's the point that, you know, we have to be able to think about what other people are experiencing and feeling, you know, and that's the politics of empathy. And that's the politics of our mentoring. Okay, I'm going to shift over a little bit and give you some of the things I've learned through life, from everything from my father to Kate to Victor, from my dog, Max, and again, kindness, empathy, healing. You know, we're all healthcare people. We're in the process, a field that is involved with healing. Always, always, always begins with kindness. I was on a radio show last night and listening to people calling in, and oh my gosh, the sadness, the terrible situations people were in. And, you know, the right response always was, I'm so sorry to hear what you are going through. This is very hard, and let's think about ways that this could be better. That's, I think, where we begin as mentors. I've learned this from my great grand Labrador Retriever, Max. And when I lived in Los Angeles, I had very bad mentoring. I had chairs that were constantly fighting and criticizing people. And in my work, I learned to be slightly paranoid and critical of people around me. And at the same time, we had this young, brilliant Labrador puppy that I used to run with on the horse pass. And he was great in every possible way, except when he saw male dogs, he would often get in fights. So here I am at work fighting with people over nothing. And then I'm on the horse trail with Max, fighting with other dog owners, trying to pull their dog off of my poor little baby. And so this was a time of great stress. So one day, Max and I were running. He saw this Siberian Husky. He loved the dog, and he started wagging his tail, and and I said, Max, that's your friend. And so he got it. And so from then on, whenever we'd see a dog coming, I go, Max, that's your friend. Immediately, his tail would start to wag, and all of that negative anger and aggression that had happened before just melted away. And I learned from Max. So in my real world, I toned down the language. One of our faculty recently used language that, wagging our tail is really linked to how we say things. And if we say things in a way that is confrontational or condemning about someone else's values, expect the fight to begin. But, I think I now always assume that people are there as my friend. My job is to be helpful. And I think that's really probably the most amazing thing I've learned in my, career as a mentor. And even more amazingly, I learned it from a really smart Labrador Retriever. So the other thing is, the older you get, the more you realize it's not about you. Victor exemplifies this. He's running all over the world, writing grants with people, other than helping and altruism and feeling good about doing something for a person he likes and the world around him. That's the reward. It's not taking 20% of the grant. It's not being first author on your junior person's paper. It's not about you. It's rooting for your mentee. My dad was a socialist. He used to say, everyone counts for one. And he acted that way. You know, when he, walked into the hospital, he knew the janitors every bit as well as he knew the head of the hospital. And I think that concept of democracy is incredibly valuable as a mentor. And you never know when that, sense of democracy will help you and other people. I always say to people, thank God, the gods of luck that you were at UCSF. I think for you in Colombia, appreciate the environment you're in and realize how much you get from it. And then Virginia Sturm has taught us that living with awe and gratitude is good for our body, for our brain, for our longevity, for our mood. And actually incorporating all walks into the daily life of caregivers had a profound physiological effect on the caregivers. All right, so here's selection. And as Victor and Kate know, I spent a lot of time getting other people's opinion about bringing someone new in. And here's the punchline here. Choose your colleagues wisely. If you choose the wrong colleague, it's going to increase the stress that you'll experience for as long as that colleague is around. It's easier to root for people who you really admire and think are great than people who you have real concerns about their ethics, whatever it is. I think in general, good leaders avoid negativity. Avoid people who explain why things can't get done. Usually they can get done, and it requires a lot of work. But my goodness, approaching the world in a way that says, we can't do this, it is not going to be very helpful to anyone. Donald Trump likes to talk about how great he is. And of course, the point is you shouldn't lead alone. You aren't that good. I have massive deficits in my brain, that must be complemented by people around me. Once Kate Rankin said to me when I was, talking about something, she goes, Bruce, you're really good at figuring out, what we should do, but the pathway to it, you're not so good at. It's really true, and that's why, working together with people who are really good at that, Victor, Shireen, Kate, those are people who they may perceive as smarter, more successful, more handsome, whatever. It's a bad strategy. The better people you work with, the more successful you will be. We have lots of hard decisions to make, and try to understand what your voice is. Finding your voice, just like a writer, is key to understanding how to mentor. So follow your feelings and your voice. I would have ended up at a university with very little opportunity if I hadn't listened to my own voice and my own heart when I came to UCSF. And the last point I think is really, really important. Unfortunately, you are going to get a lot of bad advice. Sometimes it's, inadvertent, sometimes it's even malicious. But I think you're going to have to think through all the time, the advice you get, and think about, should I listen to this, or is this something that maybe I should pass on? And I still do this to this day, all of the time. Okay, here's some quotes from people I admired. We should never simply write ourselves off and see ourselves as a victim of various forces. I always have a tendency to do this. Woe is me. This is, so unfair. How could this happen to me? But ultimately, we decide where we are, who we work with, and, we have to own it. Otherwise, we'll be in a constant state of regret. That's a great filmmaker, Richard Linklater. My dad always said this, you know, and people forget this. You know, we are expected to meet all sorts of diversity. The bumps in the road are the road. That's just life. We have had unbelievable adversity, unbelievable bumps with the current administration around grants. We have to deal with it. We have to respond to it. Do we like it? No. Is it fair? No. But that's just the bumps that we accept when we become academics. I say yes to a lot of stuff. For no reason in the world should I have been on a radio show last night that lasted from 10:30 to 12. Anyways, I say yes. And usually something good happens from saying yes. We can't say yes to everything, but the more we can take on, the more good we do. And you know, and I also like to say, when we say no, think of all the doors that might close along that opportunity that we say no to. So I think I tend to, and I think a lot of good leaders tend to have a yes kind of perspective. In the 1960s, I went to a demonstration, and this is what we call in GBHI the elevator talk. Be able to say in a few words, Bobby Rush, a Black Panther, said it to one of the speakers who did a terrible job. Get your rap down. You know, people say in the first minute of an interaction, people are either lost or with you. So know what you're going to be asked to talk about, be eloquent about it, practice it. The more we practice it, the better we are, and the more likely we are to persuade people. Authenticity, I think we've decided at GBHI, in part comes by pushing outside your comfort zone. My comfort zone as a teenager was shy, book reader to myself. And in the 60s in college, I moved out of that space. And, you know, it did immense good for me. This is the great aviator, one of the Wright brothers. No bird soars in a calm. So I think it sort of says that, you know, when we are faced with challenges and we meet those challenges, we become better than if we hadn't faced those challenges at all. So see the bumps as an opportunity in some ways. This is about values, and I have real peace of mind in my GBHI space. It produces the right values. The right values produce the right thoughts. The right thoughts produce the right actions, and the right actions produce work which will be a material reflection for others to see of the serenity at the center of it all. So of course, when you do something great, it reflects something within your brain that other people will recognize as very important and special. This is Robert Pirsig. Nobody taught me more about values than Robert Pirsig. Robert Pirsig had schizophrenia. He worked on getting a PhD at the University of Chicago, hated the mentors, wrote about it in Zen and the Art of Motorcycle Maintenance. But look at someone with a slightly different perspective on things, how much we have learned from him. Okay, this is selection again, circling back. Choose the right people, trust yourself, talk to many, trust what other people say. One of the rules of thumb we have in GBHI selection is if one person is really concerned about a candidate, we all take notice. Conversely, if one person says this is an extraordinary person that we can't miss, you know, we collectively have to take that very seriously. I've had a lot of people who apply for something and they say bad things about their previous environment. Of course, that's someone you probably want to avoid because you know soon they'll be saying bad things about you. CVs are helpful. They tell us about what someone did in the past. Don't tell us much about the opportunities that they had. For some people, maybe they had none. So they're not everything. And I take very seriously that person that I engage with in an interview and thinking about, you know, who is that person? Are they open? Are they going to listen? Are they going to learn? Are they rigid? You know, so CV is not everything. Going to a good college is not everything. Here's what you need in your employees, your mentees. They really want to work with you. Nothing worse than hiring someone who really has a different plan. I'd rather be down at Stanford where I think it's more prestigious. You know, this is not, you know, this is not a formula for happiness. People need to really be good at the job you hire for them. I think if people don't have a good heart, doesn't matter how smart they are, doesn't matter anything else. If they do not, you know, have empathy and care for others, then this is not going to be a fun relationship. And then ambition. This is what Robert Pirsig called gumption. I love this concept. Person filled with gumption doesn't sit around stewing about things. He or she is at the front of the train of their own awareness, watching to see what's up the track and meeting it when it comes. That's gumption. If you're going to repair a motorcycle, an adequate supply of gumption is the first and most important tool. If you haven't got that, you might as well gather up all the other tools, put them away, because they won't do you any good. I think gumption, if I had to guess, is strongly related to the size of our anterior cingulate cortex. This is the drive that says, I can do that, I have a plan, and it's important to finish it. That's a great quality in mentees. So what if you don't get those people that are incredible? Doesn't matter. Your job is to do the best with the hand you are dealt. You know, a lot of poker players win with a pair of fives. Bring out the best in your best and bring out the best in your worst. And I've learned over the years that some people who I really worried about, who I would have put in that worst category, by being patient with them, they turn out much, much better. You can't really be effective if you don't delegate. You know, all of us, Victor, Kate, we have people around us who really help us carry out our mission. And if we have to put our hands in everything that happens, you know, we're going to make a mess of things. Find people who compliment you, stand behind them, pay them well, formalize fun and teamwork. People come to work with you and they don't enjoy the interaction. They're not going to look forward to seeing you again. You know, so I think taking time in your day-to-day work to actually engage with someone outside of task is incredibly important. Chance to talk. The result is a kind of endless day-to-day shallowness, a monotony that leaves a person wondering years later where all the time went, and is sorry that it's all gone. Some final principles. The easiest person to change is you. That's my dad. When I used to complain about someone, he said, well, you can't change that person. You know, what could you have done better in that interaction to make things go better? And, you know, I think that's always our task as leaders, is not to blame the person for whom you are not happy. It's thinking about what you could have done differently to help that person. I think people don't like to have a oppressive force managing them all the time. I try to leave people alone if it's all possible. Place to improve the world is first, and going back to the beginning, is one's own heart, head, and hands. And this is probably the most important, I think, quote in Zen and the Art of Motorcycle Maintenance. The real cycle you're working on is a cycle called yourself. So recently we had one of our trainees complain that they had to do too much work on a project and other people, you know, didn't take up their responsibility. True, true. On the other hand, I find that every time I am made to do work around something, This is improving my brain. This is improving myself. And, so I think it's another way of thinking about, I don't care so much about what other people are doing. I really care about what I can do to make things better. And ultimately, that's making me better. That's a gift to me. Okay. Do more than share your share. Usually you're the beneficiary of extra work. Get advice. Watch bad leaders and good leaders. They are your teachers. Anger. I've had 1 or 2 episodes of anger in my life at UCSF. I regret them. They did nothing good. All it did was let people to think less of me. Except occasionally, maybe, rarely when a huge principle is at stake, but not very often. Okay. Finally, quality. Quality fans out like waves. The quality job that you didn't think anyone was going to see was seen. The person who watches that or feels it is a little bit better watching you and is likely to pass that feeling on to others. And in that way, the quality tends to keep going. I think this is we have at the Memory and Aging Center. We get people, doesn't matter what their title are. My assistant, Carolyn, doesn't want any fancy title. Shireen doesn't want any fancy title. They do such high quality work that it is breathtaking. And watching someone do that can only make you want to do things in a higher quality way. So as you develop your teams, I think this becomes one of the most gratifying things that can ever happen. And then finally, for your staff, life outside of work is more important than life at the office. Help make that life outside of work better for your staff. People will eventually leave you, accept it and embrace it. Okay, so I think I'll stop there. I could read something really quickly, but I don't have to. What do you think, Victor and Kate? Should I take some questions?
Yeah,
Or
I think, yeah. Maybe we're about 10 minutes to the next presentation, so it might be good. I don't think you can see us though. Did you get this?
He's seeing us.
Oh, are you seeing?
Yeah, the camera is there.
For some reason, it's showing the speaker.
Yeah,
up
because
front,
it's camera.
and I can't get this camera to work, so.
Can I get any questions from the audience that somebody might want to ask Bruce?
Okay,
Pablo you got the 2 Atlantic fellows with their hands high.
yeah.
So Pablo's coming up before Nanos.
Yeah. And the microphones work?
Bruce, can you stop sharing your screen so we can see?
Yeah. Oh, good point. Good point. Thanks, Kate.
Okay, you talked many times about the wisdom. So I would like to know from a point of view, what is your wisdom? Because wisdom is a huge word, but for you, what's mean?
Yeah, well, wisdom, I think it has 2 pieces. It has the accumulation of knowledge and experience. The more experience that we accumulate, I think the more potential for wisdom. So that's one part of wisdom. And the other part of wisdom is, I think, tied to this idea of pro-social behavior. What do we do with information that comes to us that allows us to help other people? So I think, some of it is facts, some of it is physical experiences, and some of it is that voice in our head that thinks about, I've been given this extraordinary opportunity on Earth. How can I take this information and use it to help others around us?
Thank you.
Hi, Bruce. Nano Santa Maria. We are so happy to have you here and share your thoughts and all your experience with us. I have a question regarding to, I would like to know to what extent to be a mentor of so many researchers and clinicians around the world help you to grow up and help you to change your life and your style of being clinician, to be person, to be even I don't know, a family member, to be part of your country. It's important for us to detect that to be a mentor is also an opportunity to change and an opportunity to grow up. And I would like to know what is your expertise on that.
Yeah. Well, Ananda, what an extraordinary pride we have in seeing what you have done. Yeah, I don't think that I had what we would call the right stuff when I began. You know, I emphasized too much my work accomplishments and forgot a little bit about you know, the more important things, which is you know, touching people around me, friends, family, and so a lot of the mentoring around this has come in two directions. One is from my wife, who is an incredible advisor. And she puts things in perspective for me. Not, you know, our partners often can stand apart and, you know, see what's important and see what isn't important. And I can't tell you how many times my wife has said, "Why do you care about that? That has nothing to do with you. That's so trivial or petty," or, you know, I think she has a point, Bruce, you know, I mean, you know, so having someone like Deb to reflect on these situations in life has been a lot elevating the wisdom. And then the other part is failures, you know, think of the times when maybe, you know, someone I might have helped didn't do well, did badly. You can't make everyone an academic. I learned that at my first hospital, where almost none of the trainees were interested in becoming an academic. Can't make them act. That's not part of their program. But, you know, thinking about the times when you fail and self-reflecting is really, really important. And, you know, it really builds up your sense of wisdom and ability to empathize.
Well, thank you so much, Bruce, for sharing your thoughts and your feelings with us, all your learnings. They are so important for us.
Can I read one thing to end?
Yeah.
Do we have a few minutes? Yeah. All right. So I had to write a piece about empathy, and I was coming back from Baltimore, and like I didn't want to write it. I just wanted to sleep in the airplane. And so here's a paragraph. Here's what happened. So recently, soon after takeoff on a very late flight from Baltimore to San Francisco, on which I planned to sleep, the flight attendant asked if there was a physician on the plane. As many times before, I've flown almost 2 million miles. I walked to the back of the large jet where a 50-year-old female oncologist, an immigrant to the United States, and a 30-year-old pharmacist whose style I would have said was punk, queer, extraordinary young woman. They were standing over a 50-year-old woman in severe distress. Working in harmony, this 75-year-old neurologist, 50-year-old female oncologist, and 30-year-old pharmacist determined the passenger was suffering from an allergic reaction to shrimp. Her blood pressure was low and she had intense abdominal pain and cramping. The oncologist, who told me she hadn't put a venous line in 10 years, put a venous line in, and the pharmacist held the infusion bag high so that the fluid could run in quickly. For several minutes, we considered landing the plane. I reassured this very stressed but improving passenger that she would be okay. We were there for her. After several hours, she was back in her seat, comfortable and sleeping. Upon landing, the pilot thanked the passengers for their tolerance of a delayed flight with delays in service due to a medical emergency. He asked that people remain seated to let people with connections leave first. The passengers complied. As my two healthcare friends, part of our little MASH unit, and the patient left the airplane, I quietly thanked them. I touched them. I thanked them for our work together. We briefly touched each other in gratitude. I slept well that night. Empathy and altruism carry their own deep rewards. That's it.
Thank you, Bruce. Thanks for taking time to be with us today. We appreciate it very much.
Thank you.
We'll see you very soon.
Yes.
I think we're going to keep going on. If it's okay, we've got about half an hour of dry things, and then I think we have lunch coming, right?
Yes.
Yeah, so I think we'll switch to the slide that's about IDP. I don't know which one this is. That was the last one. So, I was going to start by talking about the types of mentors. I'm not sure we'll have enough time, and I'm not sure how applicable it is. There's one, and we'll get all of these slides afterwards, so you can go through and read about things that might be interesting. But let me just tell you about how we frame mentoring. The place that it's helpful is that when somebody asks you to mentor, you have this all-encompassing idea in your head that goes from making sure they have breakfast to making sure they get
Para quienes
publications to
están
making sure they have the next job.
yendo, recordarles que hoy a
And
las
really there are
4 de la
different
tarde
pieces
tenemos
of it
nuestro
that you
evento de
can do.
cierre aquí mismo.
Sometimes you
Muchas
may
gracias.
just be mentoring somebody on how to run flow cytometry. That's a task. It's a project-based mentorship that you just really focus on that piece, but you're not necessarily responsible for the person's job. I'm sure many of you have done that. I know Pablo does this with imaging. Somebody wants to learn how to do imaging. Doesn't mean that you have to be responsible for their careers in any ways.
Para aquellos que nos vieron desde YouTube, thanks a lot for being here with us. This will conclude the transmission. We will not continue this afternoon, so we want to give a thank you to all of the sponsors, the Universidad Javeriana, the Intellectus Group, the Global Brain Health Institute, the UCSF, La Universidad de Antioquia, and the Colne. Thank you to the university for making this possible. Thank you for all of you to being here, to all of the speakers. Of course, a special thank you to all the logistics team, to Ivan Romero to make this possible, and to Hernando Santamaria for bringing us all together. So thank you again, and we hope to see you in another time soon.
Is helpful because if somebody comes to you and says,